Learning is a treasure that will follow its owner everywhere. The willingness to learn is a choice. A warm good morning to Anandol. Thank you all for finding time for joining us on today's webinar, Inside 2K22 webinar on the role of specialty contact lens in Keratoconus and Myopia Control, coordinated by Giridhara Institute and Sushruta School of Optometry and Visual Sciences. It's time to cross another milestone that we Giridhara Institute is completing 25 years of compassionate care, 25 years of improving life, 25 years of making difference. Yes, we are moving on to the silver jubilee of our institute, the most proud moment of all of us of being a part of Giridhara Institute. Before moving to this webinar section, let's have a look at the milestone that we have traveled in the last 25 years to achieve this great moment. Moving to the video.
I would like to express my heartfelt gratitude to all of you who sincerely committed to Giridhara Eye Institute for their compassionate work in the field of eye care and services, especially Dr. A. Giridhar and Dr. Kanchana for being the two pillars throughout this journey. Now, I welcome Ms. Meghna Anderson, optometrist, Giridhara Eye Institute, for the welcome speech.
Everyone, good morning to one and all. On behalf of Giridhara Institute and Sushruta School of Optometry and Visual Sciences, I welcome you all to this webinar, Inside 2K22 webinar on the role of specialty contact lens in keratoconus and myopia control. I am happy to announce that this webinar is being conducted along with the cooperation of V Square Meditech Private Limited. We have their GM, Mr. Vikas Chaturvedi, and Business Development Manager, Mr. Swastik, in this webinar. On behalf of Giridhara Institute and Sushruta School of Optometry and Visual Sciences, I welcome you both to this section. Organizing events involve dozens of little details and tasks that are vital to a success. The role of a leader is to unite, bringing together a team to pursue a common goal. Here we have our two leaders, the organizing chairman, Dr. Vinay S. Pillai, Senior Consultant and HOD of Cornea and Refractive Surgery, Giridhara Eye Institute, and our organizing secretary, Ms. Anu Kuriakos, HOD of Optometry and Contact Lens, Giridhara Eye Institute. I welcome you both to this section. Next, I welcome all the presenters who were here to share their knowledge and experience in the respective topics. Ms. Parvati, Faculty of Sushruta School of Optometry and Visual Sciences, Ms. Jasla Avi and Ms. Taslima Enes, Optometrist of Giridhara Eye Institute. Now, it's time to welcome you all who find time for joining us in this webinar. I'm sure that you will feel enriched with knowledge after completion of this section. I welcome you all once again to this webinar, and I hope that you will have a great day ahead. Thank you. Now we are moving to our webinar section. Before that, a gentle reminder, to keep the quality of sound function during this webinar, please mute yourself. If you have any question during the sections, feel free to type them in the chat box. It will be discussed and cleared in the end of the section. Without further delay, we are moving to the first section, Introduction to Orthokeratology. This section will be handled by Ms. Anu Kuriakos, HOD of Optometry and Contact Lens Department, Giridhar Eye Institute. Moving to you, ma'am.
Good morning, everyone, and welcome to my presentation. First of all, let me thank you all for attending this virtual webinar. Today, I am going to talk about Introduction to Orthokeratology. This section will be covering basics of orthokeratology. Moving on to the definition. The word orthoke literally means straightening the cornea. It's a Greek derivation. The aim is to reshape the cornea. It's revolutionary, non-surgical, completely reversible procedure that eliminates the need for glasses or daytime contact lenses. Orthokeratology having so many alternative names, few of the common names are listed here. Corneal reshaping therapy, vision shaping treatment, corneal refractive therapy, accelerated orthokeratology, corneal corrective contact, eccentricity zero molding, gentle vision shaping system, overnight corneal reshaping. Moving on to the historical milestones. The purpose of using orthoke to correct refractive changes is based on long established science of orthokeratology. The science is not new. The thinking dates back to the ancient Chinese. It is said that Chinese soldiers first stumbled upon a form of orthokeratology when they would sleep with sandbags over their eyes. Upon waking, they discovered they had improved distant vision, which enabled more precise target shooting for their archers. In 1962, Dr. George N. Jessen introduced orthofocus conventional geometry lens, where he was able to manipulate refractive changes up to 1 diopter. He is considered as the grandfather of orthokeratology. It became the first stepping stone to the science of orthokeratology. Reverse geometry lenses are introduced by Fontana in the year of 1972. Overnight shaping was revived in the 1990s. Modern orthokeratology lenses are available from 1990 onwards, but the big breakthrough came with the convergence of new technologies. In 2002, Paragon CRT approved for overnight corneal reshaping. Euclid or orthokeratology lenses was arrived in the year of 2004, and 2005 toric orthokeratology designs introduced at the Global Orthokeratology Symposium. What is an orthokeratology lenses? Orthokeratology lenses differ from standard gas permeable lenses in both their wear schedule and design. Where gas permeable lenses are worn throughout the day, but an orthokeratology lenses are worn while patient is sleeping. As the patient sleeps, the lens works to reshape the corneal epithelium. When comparing the designs, the traditional GP lenses have a central base curve and progressively flatter peripheral curve. An orthoke lenses has a flat central base curve and a steep peripheral curve, that is a reverse geometry design. There are generally 3 zones that make up an orthokeratology lens. The zones are the treatment zone, reverse curve or return curve, and the alignment zone. What is treatment zone? Treatment zone is the central portion of the lens that flattens the corneal epithelium centrally. The base curve is a key aspect of the treatment zone. The reverse curve works to return the treatment zone of the lens closer to the cornea and it allowing desired applanation. It is also a key component in achieving a centered fit. Third one is the alignment zone. Alignment zone is the periphery of the lens and it is critical in the stability of the contact lens fit. The zone counters to the cornea and it helps with the centration and movement of the lens. Who are candidates for orthokeratology? Orthokeratology are approved to treat up to 6 diopter of myopia, minus 1.75 astigmatism, with the rule astigmatism, and 0.75 against the rule astigmatism. But typically we are correcting myopia, but other type of refractive errors and presbyopia can be corrected by using orthokeratology. But however, the best results can be achieved with little or no amount of astigmatism and low amount of myopia. Poor results are more likely in patients with high refractive error and irregular corneal disorders. Apart from these factors, a good candidate should be highly motivated and keen to maintain proper hygiene and care of the lens, and also willing to have multiple follow-ups to ensure proper fitting and treatment. What are the benefits of orthokeratology? It provides a reversible way to treat myopia. It allows patients to go throughout the day without the need for spectacle or contact lens correction. This makes it a great option for athletes and other individuals who would like clear vision during the day. It also benefits for those who are not interested in refractive correction surgery. The main use of orthokeratology is to help slow the progression of myopia. What are the drawbacks of orthokeratology? Orthokeratology is not a permanent solution. Patients should obey frequent follow-ups, that is 4 to 10 visits in 3 to 6 months for the best result. As orthocare is a reversible process, patients need to over a retainer lens throughout the life. It may not be successful in some cases, and the rate of success varies from person to person. It is contraindicated in some ocular disorders like severe dry eye, allergies, keratoconus, etc. Chances of microbial keratitis in overnight orthocare wear more than an open eye wear. What are the potential complications of orthokeratology? Similar to other RGP contact lenses, there are risks with the wearing of orthokeratology lenses. So, the main concern is microbial keratitis. Although the chances to get infection is very high because orthokeratology lenses are worn while patient is sleeping. When handling and wearing contact lenses, hygiene is always important. Washing before inserting and removing contact lenses, to use appropriate disinfecting solution for cleaning and storage, avoid direct water contact to the eye by contact lens wear. These are best ways to avoid infection. Apart from this, other complications can result from improper fit such as corneal defects and irritation. Some patients also experiencing halos and ghosting around the light. These are more noticeable. These symptoms may be more noticeable in low light conditions such as low light condition when the pupil size increases. How do you fit an orthokeratology lens? Obtaining a proper fitting lens is crucial, not only to avoid complications, but also the success of correcting refractive error. Key to this process is baseline corneal topography, patient manifest refraction, anterior and posterior segment evaluation. HVID and pupil size are also important consideration. Customize the design of the lens. Designing the lens can be accomplished either empirically or diagnostically. What is empirical fit? Empirical fit lenses are designed with the help of lab consultant using the patient eye specifications. No trial lenses are involved in this empirical fit. The first lens on the patient's eye is made for them. Changes can be made to improve treatment, centration, movement, and other consent. When fitting diagnostically, a trial set is required. A trial lens from the trial set is placed on the patient's eye according to the eye parameters and fitting guide. A custom lens is then designed, evaluated with the fluorescein and over refraction of the trial lens. An ideal orthocare fit. In the either cases, the ideal end result would have a defined treatment zone. that is centered, cover the pupil with appropriate return and alignment zone. You can see here there is a central area of darkness that is around that is about 4 millimeter, which is created by base curve and optic zone, surrounded by a sodium fluorescent ring that is about 1 to 2 mm. Under that is reverse curve and reverse curve or return zone. Under the reverse curve, that is surrounded by a dark ring that is about 1 to 2 mm, that is alignment zone. Finally, you can see a narrow sodium fluorescent. It's about 0.5 mm under the edge of the lens. Determining the edge lift of the lens. An ideal ortho-K fit look like a bullseye pattern. Each area of our importance to create a proper fit. How orthokeratology works. The flatter lens in positive pressure or applanating force on the cornea induce a possible compression and flattening of the corneal epithelial cells without actual loss or migration of the cells. In myopia, thinning of the central epithelium occurs due to applied pressure and decreasing the number of cell layers, and thickening of the mid-peripheral cornea occurs due to increasing the number of cell layers and enlargement of cells. In hypermetropia, thickening of the central epithelium occurs due to the increasing number of cell layers, and thinning of the mid-peripheral cornea occur due to applied pressure. Effect of orthokeratology. This depends on many factors, especially amount of refractive error. Some people can have excellent vision after a day or 2 days of overnight ortho-K wear, but higher prescription can take 1 to 4 weeks to achieve excellent vision. The treatment temporarily reshapes the cornea. Without consistent use, the effect will be wear off. Wearing the contact lens every night will provide a better result. Moving on to the follow-up schedules. As stated previously, fitting orthokeratology requires a dedicated patient who is willing to have a multiple follow-up. Each follow-up consists of obtaining a proper case history of the patient's lens routine, vision assessment including refraction, updated topography, contact lens fit assessment. Patient should present to clinic wearing the contact lenses. The first follow-up should be the morning after the first night of wear. Follow-up visits are usually held after 1 week of wear, then 1 month, 3 months, 6 months, and then about every 6 months to a year. For children, tighter follow-ups are recommended. I concluded that orthokeratology lenses are specialty contact lenses that provide qualifying patients with a temporary non-surgical option for correction of the refractive error. Unlike traditional contact lenses, these lenses are worn throughout the night, allowing the patient to go throughout the day without the need for refractive correction. Complications related to orthokeratology lenses are rare and can be the best prevented by maintaining proper lens hygiene, proper wearing of lenses, and following up regularly with the lens provider. Orthokeratology is a safe, effective means to provide a clear vision during the day and reduce dependence on glasses and traditional contact lenses. And also it will help to slow the progression of myopia. Thank you.
അടുത്ത സെഷൻ ആണ്
തുടങ്ങിക്കോട്ടെ.
Thank you, ma'am. Moving on to the second session, myopia control and orthokeratology fitting. The session is presented by Mr. Vikash Chaturvedi, General Manager and founder of V Square Meditech Private Limited. After this session, we will have a small discussion, so feel free to drop your questions in the chat box. Here is a brief introduction about our presenter. He is a certified optometrist from RP Center, Ames, and had a rich experience of more than 15 years in different ophthalmic NNCs. He had completed certification course on contact myopia control from Baden Holden University. Handing over to you, sir.
Thank you, ma'am. So I will share my screen. So can you, is my slide visible?
Yes, sir.
Okay. So thank you so much and good morning, everyone. I want to special thanks to Dr. Vinay sir and Anu ma'am for giving V Square the opportunity to talk on scleral contact lenses and orthokeratology. I am going to talk on orthokeratology and myopia control, and my colleague Mr. Swastik will be talking on scleral contact lenses. So a small introduction about V Square. V Square, we deals with scleral contact lenses, orthokeratology lenses, and dry eye products. We have a diagnostic as well as a therapy equipment for dry eye, as well as the home therapy for dry eye also. So coming to my topic, myopia control and orthokeratology. Myopia control. So why means it becomes a hot topic nowadays, myopia control, and this is because of this particular study done by Baden Holden University. We know that 50% of the world population will become myopia by 2050. But the more alarming factor is the high myopia. So as per this study, 10% of the total world population, so somewhere around 1 billion of the world population will become high myopic by 2050. So, and we know the challenges of high myopic patients. There are a lot of risk factors associated with high myopia. Glaucoma, cataract, and visual impairment from myopic maculopathy, macular degeneration. So these all are very common, and we have seen a lot of patients having high myopia coming with all these associated problems. So the need of hour is to control myopia, and for this I'm going to talk on some concepts related to myopia and one of the optical intervention which is very, very common in myopia control, orthokeratology. So the normal factors of myopia is like genetic factors is one of the crucial factor, and we see that one myopic parent can cause a risk factor of 2 times, as well as for both the parents it's 6 times. So environmental factor also plays a very important role, especially in the development of myopia. And we have seen that there are a lot of studies which say that development of myopia can be controlled by vitamin D. Next, optical factors like accommodation lag and binocular vision problem. We know that nowadays, because of the situation, means children are forced to do a lot of near work at their home. They have to use the laptop for online classes, tabs for the online classes. So these are also very, very important associated factors for myopia growth of myopia. Now, if we talk about the management of myopia, so till now we have seen that this is the most common in India, we can say, not everywhere, but yes, in India it's very common that as far as myopia management is concerned, we are talking more about the eyeglasses, spectacles, single vision spectacles, single vision contact lenses. In the childhood days, like in the age between from till 18 years of age. And then if the patient is very want to be independent of spectacles, they don't want to wear spectacles, then we go for some surgeries like LASIK, ICLs, clear lens extraction. But we need to understand that these whatever methodology or whatever management we are following, so all these methods like eyeglasses, contact lenses, these just correct the myopia. But the need of an hour is not just to correct myopia, but to control myopia also. So what is what do you mean by controlling myopia? The controlling myopia is basically we are trying to slow down the progression of myopia. There is always some, if you see the control factor, so we have always seen that some percentage is always associated with the myopia control. Let's say 50%. So what do I mean by 50%, or what do the studies mean by 50%? So 50% means that the progression rate, suppose the progression per year is 1 diopter per year, then with the particular methodology, whatever we are using for controlling myopia, if it says that it controls myopia by 50%, that means the progression rate will be slowed down by 50%, and it will progress just by 0.5 diopter, not by 1 diopter, which was before the control. So this is about the myopia control definition. Now, why means what are the factors which help us to understand that how we can control myopia? And this study, I want to bring you to your notice this study by Professor Earl Smith. This is a very you can say this is a very crucial research which happened in the world of myopia control, and mostly all the optical intervention which is available in the market right now, they all basically believe this particular study, and all this research, everything is happening based on this particular study. So this is a very, very important study, and we need to understand the two important facts or the findings of this study. The first one is that as per Professor Earl Smith's study, the functioning phobia, which is actually for the focusing the images, is not essential for normal axial development. So whenever we are talking about the axial development, that is myopia control, we need to understand that the functioning phobia is not essential for normal axial development. Rather, the peripheral retinal receptors, which provide the signal for the eye to grow. I think you can understand what I want to say, that the central part, like phobia, is not important for axial length development. Rather, the peripheral part of the retina, they have the receptors which provides the signal to the brain for the eye to grow. So this is a very, very important finding, and based on this, all the optical intervention products are actually helping to control myopia. To understand in a better way, this is one example. So it's an emmetropic patient. So in emmetrope, we have seen that the myopic, the central rays are actually focusing, since it's emmetrope, so it's focusing on the retina. Not only this central, it is focusing on the central part, but even the peripheral rays are also focusing on the retina only. So in case of emmetrope, everything is focusing on the retina, and that is why there is no different signal. So if you see, so there is a single signal from the central receptors as well as from peripheral receptors. So the peripheral receptors is also focused, and the central receptors is also focused. Now, how do we diagnose the children for in refractive error? So in school screening, in a patient comes to OPD, they can't see the board. So these are the ways where parents come with their children that I want my child to have a checkup, vision checkup. So we do a checkup, and then we, based on the refractive errors, which is myopia, then we prescribe spectacle lenses, single vision spectacle lenses. So if you see the single vision spectacle lenses, so in single vision spectacle lenses, now since it's a myopic eye, so myopic eye is actually grown, right? So this area and this area is totally different. So now when the central rays actually, this spectacle is meant for the target refraction, so they will focus on the central retina, that is on the fovea, and we'll have a clear image. But at the same time, the peripheral rays will focus behind the retina. And this is the main, if you correlate this with the Professor Earl Smith study, then he told us that this peripheral retina provides a signal. So peripheral receptors provide a signal to the brain for the eye to grow. So now I think you can understand that what signal this peripheral retina will send to the brain now. So this is how it is. So the peripheral retina and the central retina. So this peripheral retina will send a signal, which is a main important factor for controlling the axial length. It will send a signal that, see, I am not focused. My area, my retina is not focused. So I can't. I want it to focus. So please focus these rays. So the brain then, what brain will do? Then brain will send all the messages to the eye muscles, and automatically the axial length will grow. And once the axial length will grow, this area will focus. But once this area is focused, then this area will again defocus, and this will be myopic defocus now. So this, so what will happen? Again, the children will come with a complaint that I am not able to see the board clearly. My vision is not proper. I can't see 6/6. So this is a very ongoing process. First, we correct this central phobia with a spectacle. Peripheral phobia, peripheral macula becomes hyperopic defocus. Brain will try to focus the peripheral retina, and then again the central phobia will be defocused. So this is the ongoing process. So this is how the axial length is growing as per Professor Earl Smith's study. So how orthokeratology works in this case? So as I already mentioned that all the optical intervention which is available, either it's a spectacle or it's like we have a lot of new upcoming spectacle specialty myopia control spectacle lenses and the soft contact lens, multifocal contact lenses and orthokeratology. So all the optical intervention, they work on this particular concept by Professor Earl Smith. So one finding of Professor Earl Smith is that there is a this peripheral retinal receptors are more are responsible for the eye growth, and the second very important factors what he have what he found is the peripheral, in the peripheral retina, it is off axis from 20 to 30 degrees. So the area which is more prone for this particular excellent development or growth or signal is basically the area off axis area of 20 to 30 degrees of the retina. So, and it is irrelevant of phobia. So now just try to understand this three images. So this is the uncorrected myopia. So now peripheral hyperopic defocus and even the myopic defocus, because this is not corrected. So once we go with the traditional correction, that is the spectacle or single vision contact lenses, this area will focus and this area will become myopic defocus. Now, if by any way, or by any chance, we can make some design where this macula is focused, because we need a clear image, so it's focused on the means macula is focused, and at the same time, if we can convert the hyperopic defocus, which is with the spectacle or single vision contact lenses, to myopic defocus, then of course the signal which is coming from the peripheral retina will not be there, right? The signal, mean to say the signal for the axial length growth will not be there. So this is how we are trying to design a lens where the peripheral hyperopic defocus converted to myopic defocus. To explain in the form of orthokeratology, as Anu ma'am has mentioned that this is the bullseye pattern is the classical way of understanding the ideal fitting pattern of orthokeratology. So this is a bullseye pattern, and because of this bullseye pattern, this area will become flattened, and this flattened area will be based on the target refraction. So whatever is the target refraction, let's the patient is having a -3 diopter of myopia, then this area will try to flatten by in form of a -3 diopter for a better visual acuity. At the same time, the mid peripheral area will be steepened, and this steeper area will, this lens is steeper, so we can see the fluorescein pattern. And because of this fluorescein pattern, the epithelial cells migration will happen because of this particular design. The epithelial cells migration will happen from center to periphery, and we'll have a steeper area in the mid peripheral zone. So this is a topography map of the same fitting. So we can see this area becomes flatter. So epithelial cells migrate from center to periphery, and this area becomes steeper. So just try to correlate this with the previous model, eye model. So now the central area, as per target refraction, it will focus on macula, and the peripheral area, which is steeper one. So this is the steeper one, right? So the steeper one will have myopic defocus because this power is more. So this power is more. See, this power is more. So if the light is coming from this particular area, it will refract more, it will converge more, and we'll have a myopic defocus. So what we have done, ideally, we have just converted the hyperopic defocus to myopic defocus. So this is the basic concept of orthokeratology lenses to control myopia, right? So as far as studies are concerned, so there are a lot of studies and number of studies which are available on PubMed, so you can go through it. I have just tried to put 1 or 2 studies for orthokeratology, LORIC study and SMART study. So if we average all the studies, we can see that the orthokeratology can control myopia in the range of 52 to 90%. It's very, 52 and 90%. It's a big range, right? So this range is totally depends on the design of the orthokeratology. In my upcoming slides, I will try to explain you that how design can help to control myopia in a better way. So how we can convert this 50% to 90% with a better design and with a better understanding of orthokeratology fitting. So not only orthokeratology, the pharmacological intervention like atropine also helps to control myopia, but we know that 1% atropine is not ideal. So nowadays, commercially 0.01% of atropine is available in the market, and which consultants are prescribing. And we know that there are mixed results. Few are very happy, and few are actually trying to understand more about the role of atropine in myopia control. Myopia control can also be controlled with multifocal soft contact lenses and spectacles, as I mentioned. Now, I want to talk about the product which actually we are marketing in India. It's a global orthokeratology vision company. It's a GOV system. So GOV orthokeratology lenses is again a very it's a very renowned abroad because of the design of the lens, and this is one of the you can say pioneer in high myopic correction. So it can correct till -10 diopter. I will explain in the upcoming slides. And not only that, even they have done a lot of research related to the cornea, and they can correct many type of refractive errors. As Anu ma'am was mentioning that there are some limitations with orthokeratology, but we have understood that with GOV design lenses, the limitations are, now the range of limitation is very narrow with the lenses. We can actually correct a lot of refractive errors, which is not possible with the normal, or you can say the conventional orthokeratology design. What do I mean by conventional orthokeratology design? The conventional orthokeratology design is totally like four, as ma'am mentioned, so four curve design. GOV is actually a little bit different from the conventional orthokeratology design. It is actually 5 to 6 or multi-curve design. I'll come in my upcoming slides. So this is the advanced inventory system, and as ma'am Anu ma'am mentioned that this is a practitioner control lens. What do you mean by practitioner control? So it's actually a trial set fitting methodology, and GOV can correct both hyperopic and presbyopic lens have the correction, and the power it can correct is available from +5 to -10 diopter. This is already being explained to you by Anu ma'am, so I'm just skipping this slide. So there are a lot of patents available with GOV lenses on different design, like even keratoconus. You can see keratoconus is there, but it's not available in India right now. So there are a lot of patent available with GOV lenses. So these are the models, XMJ, which can correct till -5 diopter. Then we have XM lens, which can correct from -5.25 to -10 diopter, hyperopic lenses, presbyopic lenses, and others. So how to fit GOV lenses? So as I already mentioned that this is a trial set methodology of fitting the orthokeratology lenses. So there are 3 easy steps. First, we need to select the K code based on the parameters available. We select one lens from the trial set with a K code. So then we determine the power of the lens based on the over refraction, and then the size of the lens. So just for your understanding, I have just some videos related to orthokeratology fitting. So this is a bullseye pattern video. Now, if you see, so this is the ideal bullseye pattern. So good treatment zone, a better reverse zone, and then we have a better steepening area, fluorescent pattern over here, and a very 360-degree edge clearance. So this is a very, very ideal orthokeratology fitting. So now what if we have a lens which is little bit steeper or tight. So this is the example. So this is a 4-step. So what do I mean by 4-step? That GOV trial set is based on the power, like keratometry value, K code. And if the difference between one trial lens to other lens is by 0.25 diopter. So when I'm talking about 4 steps, so it's actually 1 diopter. So let's say this is 43 diopter of trial set lens. So this is 44 diopter. So 4 steps. So when the lens becomes 4 steps steeper, then what will happen? So we will not see any treatment zone. So this is how it looks like. So then we need to to flatten the lens, and we can come to the ideal fitting. What happens if the lens becomes 4 step loose? So what will happen? So we'll have, of course, we'll have better treatment zone over here, round treatment zone, but the leakage will start from this particular area, inferior area. So we'll have this area will become, we'll have fluorescein in this area. So this peripheral area, which actually need to be very in ideal cases, there should be no fluorescein over here. So then that means this lens is flat and its movement will be more. So if you see the movement also of this lens, see the movement is very much, right? So it's more than 1 millimeter, I believe. So now what we need to do in this case, we actually try to reduce the power chord. That means we steepen the this so it's loose. So it's 4 step loose. So we'll just try to steep it by let's say we steep it by 0.5 diopter. So now it's 1 diopter steep, sorry, 1 diopter flat. So we'll make it 2 diopter steeper. So this is a video of a 2 diopter steeper, means a 2 step steeper. So just a minute. Yeah, so we have reduced this leakage, right? But still there is some leakage. So this leakage, and if you compare this movement with this movement, so we can easily find that still there is a little bit of fluorescein over here, and the movement is also a little bit more. So what we need to do in this case, we just reduce, means we steepen the trial length by 0.5 diopter. So then again we can come up with the ideal fitting of orthocategory lenses. So this is how we do a judgment for orthocategory lenses. Though it looks very simple over here, but it totally depends on the type of cornea. Like for the normal cornea, as per the normal standard, like the astigmatism should not be more than 1.75 or 1.5 with the rule, and against rule 0.75. We can't correct more than 4 to 5 to 6 diopter. So in those cases, of course, this is a very simple way of holding the cornea, but cornea is not is not very we know that a lot of difference in the cornea. So based on the different types of cornea, we need to have a better topography, and with a better understanding of topography, we can mold good number of corneas. So I think what I mean to say that the limitation can be reduced if we have a better understanding of the orthocategory lenses and a topography. So maybe that is again a very different topic. So apart from that, in GOV lenses, we have a calculator, so we can put the all the parameters like horizontal, vertical keratometry value, the refractive error, cylindrical. If we are going for a presbyopic lenses, then additional power. HVID is also very important. So you put the HVID value. We recommend a manual way of doing, because we have seen that different equipments has different, means they don't give the same value. So it's always better to go manually or digitally with digital caliper, so you can measure the HVID value. Once you put all this detail, the calculator will give you the first lens to pick up from the trial set. So as so the average value, K code is the average of the keratometric value, then power code based on the refractive error, and the diameter of the lens. So this diameter of the lens, basically it depends. So you can see this 95%. This 95% mean to say that it's actually covering the cornea by 95% of that. Means if the 11.2 and the diameter is 10.6. So this diameter is also very important. The coverage is also very important. So it totally depends. If the keratometry or the cornea is more steeper, then in that case the coverage will be somewhere varying from 93 to 94%. And if the cornea is flatter, then the coverage can be somewhere around 97% also. Okay. So now about the design. So this is a very important to understand that the 4 curve design. So this is the conventional way, like if you talk about Paragon or Euclid or Seed or other lenses which are available in the market. So these are the conventional orthokeratology lenses. Mean to say it's different from the XM design or the XM GOB lenses. So they have the 4 curve. So the base curve is there, and the base curve is important for the hydraulic massage. So basically, with the hydraulic pressure, the base curve is responsible for epithelial cells migration from the center to the mid-peripheral part. So, and then there's a fitting curve, the first reverse zone, alignment curve, and peripheral curve. So what is the role of fitting? What is the role of this fitting curve? This is the space for tear circulation. So we can have a better tear circulations and epithelial tissue molding. Alignment curve, this is a very, very important curve. And this curve basically play a very crucial role in correcting as well as controlling myopia. So alignment curve, basically it is having, we have a peripheral force. So when we talk about the molding, so molding is basically is happening because of 2 factors. One is the central force and the peripheral force. So this peripheral force, so alignment curve is responsible for the peripheral force, which helps in molding process, and it provides a better centration. Peripheral curve for the tear reservoir. So this is the diagrammatic representation of how actually the orthokeratology works. So as I mentioned, so there is a central pressure, so one pressure, and the other pressure is the peripheral pressure. So the central pressure is given by the eyelid. So eyelid puts up central pressure, and it helps the hydraulic. It puts a hydraulic pressure, and the epithelial cells migrate from center to periphery. Then we have peripheral pressure. So this peripheral pressure is again divided into horizontal and vertical pressure. So ideally, the horizontal force, you can see, so this is a horizontal force, horizontal. So the force is going horizontally. So this horizontal force is ideally responsible for migration of the epithelial cells. I will explain you what migration. Basically, either we can migrate the epithelial cell from center to periphery because we have to stiffen the mid-peripheral region. Other way is that we can also migrate the epithelial cells from peripheral part to the mid-periphery. So ultimately, what is our goal? We have to increase this zone, right? Steep this zone. So we can do by 2 processes. One is by the central pressure, and the other by the peripheral pressure. This peripheral pressure is basically the horizontal force is more responsive for the peripheral pressure. So here actually, and this basically the peripheral pressure is basically from the alignment zone. So this alignment zone is also very, very important for a better myopia control and correction. I will explain in my upcoming slides. So as I already mentioned, there are 2 curves, 2 designs. One is the XMJ lens and the XM lens. So XMJ is basically till -5 diopter. So what does the means? They have the unique XM curve to help with molding. This is a patented technology, XM design, and I will explain you how it's different from the normal curves. Then the aspheric design, which is having enhanced peripheral force. So this enhanced peripheral force means to say that it provides more peripheral force from the horizontal side and helps in molding. And it also, as like others, it's responsible for the centration and stabilization of the lenses. Because of this XM design, XM curve, the effectivity of molding is very faster and for the longer period of time. So this here actually it helps to understand that how we can have a better control and correction with the design. So if it mold faster, so it can mold faster, so we'll have a better outcome. And if we can maintain longer molding, mean to say that all throughout the day we have a stronger myopic defocus force, then that means the stronger the myopic defocus force, better will be the control. So suppose the molding in the morning hour, the myopic defocus is in the range of 8 to 10 diopter, but by evening or let's say in the afternoon, it reduces to 2 diopter. So that means if the myopic defocus is by 2 diopter in the afternoon, that means it is just behaving like a soft multifocal contact lenses. And soft multifocal contact lenses have the myopic defocus of 2 to 2.5 diopter, because that is the addition power which we are actually adding the lenses. So that means if the molding, if we want a better result for the myopia control, we need to have a design where the molding can be maintained for a longer period of time with a stronger myopic defocus. So the high myopic systems, as the name suggests, XM lenses, it can correct till -10 diopter, and unique XM curves to help molding. Aspheric design, the same thing, like enhanced peripheral force and better centration. So what is the mechanism of XM curve molding? So XM curve molding, as I mentioned, that the peripheral force is very, very important, and XM design helps to enhance the peripheral force. How it does? It actually maximize the horizontal divisional force and minimize the vertical divisional force. Now, let me give you one example with this particular slide. So, where we are trying to mold a cornea with a particular with the same keratometric value. So, let's say this is the cornea, right? And we want to mold this. We want to correct this. So, what we'll do? We will migrate the epithelial cells from the center to periphery. So, the center will become flatter, and the peripheral we will have a steeper. So, this is the steeper zone, right? So, suppose we want to do more, then we will move more of the epithelial cells, and we can do this. But there is a limitation. So we can't migrate the epithelial cells more than 20 microns. So there is a limitation. So this is the limitation now. So suppose we have crossed that, we have come to that limit, like -5 diopter of myopia. So now, so this is how it happens. So it will move the epithelial cells from center to periphery, and we'll have a stiffening over here, and this area will be flatter. But we want to mold more. We want to give more corrections. So what we can do? So the same thing till now. So this is the compressed epithelial depth, which is same in both the design. This is the normal edge profile. That means the maximum steepening which can be possible with the normal edge profile lenses. Now this is a confirmed edge profile with XM design. So why? So what I mean to say that the epithelial depth is same. This is same for both the. So we have migrated just the same way what these lenses have done from the central part, but still we have a bigger edge, steepening zone. How we have done this? So this is done by XM curve design. So what does XM curve design do? Just I will explain in my upcoming slide. So this is what we have done. So this is the correction with the normal edge profile, and this is the correction with the XM edge profile. So the power correction is more with XM design compared to the normal edge profile or conventional orthokeratology lenses. So just for your understanding, so this is the curve. This is the basically this is the XM curve design. This is the normal F4 lens curve design. So so this is the normal 4x curve lens. So this is the cornea. So this is the initial fitting. So when we have started to molding the lens, so this is how the lens will sit on the cornea in both the cases, right? So you can see this is more steeper, right? So this will mold more. So now in the final molding, this is how it is. So same way it is confirming with the cornea, and this is also confirming with the cornea. But in this case, the since it's XM design, so this XM curve, this is the XM curve. So this XM, so this blue one is the curve, and this red one is the cornea. So this is how it is confirmed with the cornea to get more power. This is with the normal design lens, normal profile. I'll try to explain more. So this is the extreme reverse geometry design, and this is the conventional reverse geometry design. Eyelid pressure is there. Peripheral curve pressure is there. Same here also, but design, because this curve is different, the design is different, this curve is different, this relief curve is different, the curve shape factor is different. So that is why it enhances the peripheral pressure. Basically, it increases the horizontal pressure more than the vertical, and we can correct more of the correction. So this is the design on the cornea final lens. This is how it is giving more pressure. and trying to migrate these peripheral epithelial cells from center to periphery. So there are two. The gist is that there are two ways of increasing the stiffness of the cornea. One by migrating the cells from center to mid periphery. So this is done by the normal RG profile lenses. The other way is that we use two factors. One, of course, the migration of central epithelial cells from center to mid periphery, and the other way is that migrating the peripheral epithelial cells from peripheral part to the mid peripheral part. So by this also we can increase the stiffness, and we can collect more diopters of myopia. So these are few examples of how we have done. So now we have understood. Do I have time now? So I'll try to finish as soon as possible. So orthokeratology, it's the best way of controlling myopia, but I mentioned in my previous slides that the range varies from 52 to 90%. So how we can actually have a better control with the lenses, how we can increase the control. So we can increase the control by, of course, by having a better myopic defocus lenses, and I will try to explain how we can actually do that. So if you see the normal ratio between the myopia treatment zone, flattening of the treatment zone, and the steepening of the rim, that is the mid peripheral zone, it varies in the range of 1 to 1.5, means 1 to 1.5 diopter ratio. So 1 is to 1.5 diopter ratio. So suppose the flattening is by 3 diopter, then maybe the steepening will be by 4.5 diopter, let's say. So this is the ratio which is actually common with the orthokeratology lenses. And based on the study, we say that whosoever is actually trying to do the ratio by 1.5 to 1 ratio, then the control will be in the range of 50 to 60%. And if we can increase the rim steepening factor, then we can have a better control. Why we can have a better control? As I already mentioned, that if we can increase the steepening rim, that means we'll have a more myopic defocus. More myopic defocus mean to say longer myopic defocus in the waking hours. So the durability will be more, because anyway it's a reversible process, right? So if the myopic defocus is still remains stronger in the night hours, in the evening hours, then of course the control will be better than the lenses which have a lesser myopic defocus. So that is why we have seen that soft multifocal contact lenses where the myopic defocus is only by 2 to 2.5 diopter, the control is in the range of 30 to 40%. That is the only reason, and that is the only reason why orthokeratology, since the molding, this myopic defocus is in the range of 8 to 12 diopters. That is why they have a better control than soft contact lenses. But if we can increase the the molding factor for longer hours, then we can have more better myopia control. So this is one example, like say 43 diopter of 42 diopter of flattening of the normal cornea. So target refraction is -3, focal lens design. So if you see the treatment zone, it's steepened flatter by 3 diopters, and this area the steepening is by 4.5. So the ratio is 1.5 diopters. So this is the normal ideal we can do. Here also molding is happening, right? So cells are migrating from central cells are migrating from center to mid periphery. Molding is happening. We can have a myopic defocus. We can have a better near vision, means distance vision with this lens. Everything is fine, but the ratio is only 1.5. The ratio of steep rim versus this treatment zone is only 1.5. Another example, here the ratio is 1.3. So see, okay. GOV has done a study, a retrospective study on 204 eyes, 102 cases with the average age, means with the average year of study is 5 years, like 5.46 years. So this study is done on 102 cases. That means 204 eyes with average study follow-up years of 5.5 years, right? So what they have found that the I've just skipped this. So they found that the control. So control is more with. So this is the control factor. So they have seen. So this is the initial means. So they have categorized in three things. So for the initial. So when the power is less than 2 diopter, we know that orthokeratology lenses. The results are better with the high diopter. Like if the power of the patient is having power of somewhere around more than 3 or 4 diopters, then the control is better. So that is with the previous study what we have learned in orthokeratology design. So initial 2 diopter and initial if the power is in initial 2 diopter, it is more than 2 diopter, and then total. So this is the one factor they have considered. So power, low power, more power. And then the other factor they have considered is the age. Again, the age factor is very important because the progression rate is more in the smaller ages. So age less than 9 years, more than 9 years, and total. So if you see the control factor, so they have seen that if the power is less than 2 diopter, the control is in the range of somewhere around 68 to 69%. If the power is more than 2 diopters, then the control is in the range of 80%. And the total average is somewhere around 75% in case of if the age is less than 9 years. If the age is more than 9 years, then the average is somewhere around 87%. Same in other way, the same study. This is the other way of representing the graph representation. 1 diopter progression in the initial before orthokeratology, and with initial less than 9 years of age with less than 2 diopter, and with more than 2 diopter, and the total. So this is the same in the representation. So this is the study about this. So what we have found from this study that 87% of the orthokeratology, 87% of the control is possible with GOV orthokeratology lenses. And why it is so? It is because of this factor which I discussed earlier. So the ratio of GOV lenses because of this XM curve design is not in the range of 1.5 to 1.3. It's in the range of 2 to 3:1. One example, same like a high power. So we have tried to explain with the -7 diopter. Yeah, so the ratio you can see it's 2.3. This is the low power with -2.75 diopter. Again, you see the ratio is 3. Even in the low diopter also, the ratio is more than 1.5 to this to 2. It's actually so in this case you can see it's 3.6. So better the ratio, higher the ratio, better will be the control. And this is possible because of the XM curve design. So as I explained, this XM curve design is actually helping for a faster molding as well as to maintain the myopic defocus. That means it induces more myopic defocus with the XM curve design because of the alignment curve, which actually gives more horizontal peripheral force and helps to retain the myopic defocus for a longer wearing out. And of course, a better means more power. So more myopic defocus over here. So more stiffening of the cornea in the mid-peripheral zone. So this is all about orthokeratology. I just want to conclude this with one more technology available in our armatorium, that is the soft contact lenses. This is a day wear lenses. This is not orthokeratology lenses, but this is again a very unique design. So this is a soft contact lens for myopia control, but this is not a multifocal contact lens. Just try to understand that this is not a multifocal contact lens. This is a different design altogether. Day wear lenses, and this mimics the design of the orthokeratology, and that is why it's known as soft OK. And it gives a peripheral rim. So the power, the myopic defocus is here also. It's same like orthokeratology, is in the range of 8 to 20 diopters. This is the design of the lens. So if you see, we have done a topography on top of the contact lenses. So this is with the contact lens. So this is the flatten and this is the stiffening area. So you can see here. So this is again the myopic defocus is more. It's not like the multifocal contact lenses. If you do a topography with the multifocal contact lenses, you will not get this myopic defocus. You will get somewhere in the range of more than that with 2 diopters, right? So 2 diopter or 2.5 diopter. But here, if you see, the difference is more than 10 diopter, right? So 43 to 51. So 10 to 8 to 20, 12 to 20 diopter of difference is possible with the soft focal lenses. How this lens is designed? This lens is there is a flexor in the lens in the 360 degree. So so this is how it is. So there's a flexor, so on 360 degrees, so you can see a fluorescein, just like orthokeratology. We don't recommend to do a fluorescein analysis with this lens because the soft lens. This is just for understanding. This is a high molecular weight to follow fluorescein has been used just for your understanding that it will just mimics the design of orthokeratology, but it's a soft lens, day wear lenses. So it corrects till minus 15 diopter of myopia. And it, as far as astigmatism is concerned, it corrects till minus 1.75 to 1.5 diopter of astigmatism. So few examples. So what are the benefits of soft focal lenses? Better comfort. It's a day wear lens. PBS multifocal contact lens means PBS technology. It simulates the orthokeratology, excellent centration, bigger optical zone. What do I mean by bigger optical zone here? That if the power increases, the optical zone can decrease. Like though orthokeratology, GOB lenses can correct till minus 10 diopter, even we have seen cases with minus 11 and minus 12 diopter also. But more the power correction is, the optical zone will become smaller, and that is why few patients can have a complaint of halos because of this. So optical zone will be smaller. But with soft focal lenses, this problem is solved. So they have a bigger optical zone for better far vision, and there's no complaint of halos and it can correct astigmatism till minus 1.75. So this is a study based on meta-analysis study with soft focal with other orthokeratology lenses study. So we can see the axial length is better with this axial length control is better with soft focal lenses compared to the other orthokeratology study done by different researchers. Even with they have compared with the atropine also 0.05. Safety. This is just some pictorial representation. It's a 1 year safety, so you can see everything is normal. Cornea is very clear. So this is all from my side. I would again like to thanks for your patient hearing. I don't know, I make it easy or it's little difficult for you to understand, but I've tried to explain you how orthokeratology works and what are the things we need to understand for a better outcome for myopia control. So thank you from my side.
Thank you, sir, for such an informative section. Many of us are hearing this for the first time. It was really useful for us. So we are moving to the discussion part. Before that, apologizing now, we have started our live streaming on the YouTube. Sorry for the delay. It occurs due to some technical errors. So moving to the discussion part.
We have received some questions from our participants. One such question is, can orthokeratology lenses be given to people appearing for merchant navy and other profession to hide their refractive error? Dr. Vinay has replied to the question that it is just an option, but could be temporary and regress on stopping lenses. Since it is not a permanent procedure, he is asking, is there any ethical issue for doing it for profession which needs uncorrected 6x6? Can you comment on this question, sir?
You want me to answer this?
Yeah, if possible,
or
can
Dr.
you?
Vinay? Okay. So rightly mentioned, ethically it's not promoted as for army, because of what the criteria as per their standard is that uncorrected vision. So anyway, this is a correction, right? We are giving some correction. So they ask for uncorrected vision, and this is an uncorrected. This is not an uncorrected visual acuity, whatever they are achieving with orthokeratology. So ethically, this is not correct, of course. Whosoever means I have seen people doing this. Of course, they are doing this for the benefit of the candidates, but they also make it very clear to the candidates also that, see, we are not here to get your medical things cleared, but basically if you want a correction, we can do this. and it is up to you how you manage this thing. So basically, it's our job is just for a correction. But if something to be written, then we know that the medical board they say uncorrected visual acuity. So if they are saying it's uncorrected, then this is not an uncorrected visual acuity. We are actually correcting the visual acuity with orthokeratology. So I hope I am able to answer this.
I absolutely agree with it, with you. It depends. We have to actually talk to the patients first, clearly what is the aim of the procedure before going ahead, especially in these cases.
Thank you, sir. Moving to the next question, is it a painful process since it compresses the central cornea? Ms. Anu Kuriakos have already answered to the question that it will be uncomfortable at first, but it won't hurt the cornea and will not be painful because of the design of the orthokeratology lenses, that is reverse geometry design. So does anybody has to comment on that? Or we can just move on to the next question. For myopia control in children using orthokeratology lenses, how long it would take to get a noticeable result, and what are the strategies that we should follow as an optometrist as well as from the patient's side?
So, sir, you want to answer or I will?
No, please go ahead. I have no practical experience with ortho, so we are hoping that you can clear a lot of things here.
Thank you, sir. So basically, when we talk about the outcome, so outcomes starts not with the orthokeratology fitting. It starts with the counseling part. What do you mean by counseling part is that we need to motivate the parents that this is we are trying to slow down the progression of myopia. We're not trying to stop the progression of myopia. So that's the first thing which needs to be very, very clear in the mind of parents. Secondly, we also when we talk about the orthokeratology treatment, so it doesn't start with the fitting. It doesn't start with the topography. It starts with the other visual assessment. Like Anu ma'am already explained, that it starts with the binocular assessment. First of all, it starts with the visual acuity, then the binocular assessment of the children. So based on the binocular assessment, we can decide that orthokeratology is the right, or the optical intervention is the ideal thing for the patient or not. What do I mean to say? That suppose there is a binocular disturbance, AC by ratio is not good. So first of all, we need to control that part. Once we do that, then of course we can go for the orthokeratology and all. So even the vision therapy also can be one of the important factor for myopia control. So this all needs to be understood initially, and then we can go for option. And if everything is managed well, then of course the results are very good. There is no doubt about that. That is what all studies says. But yeah, if there is some failure, then failure is not because of the technology, it's because of the understanding from the optometric point of view. We need to do the better counseling. There are a lot of V-Square also provides the, I think Mr. Vinay and Mr. Swastik have already explained to you that we also provides the protocol that how you should start your myopia control clinic. So what need to be done first, how you need to counsel the children. So there are some online tools available from international orthokeratologists, like from myopiaprofile.com. He's a very one of the best orthokeratologists or myopia control for within the vision therapist worldwide. So there is a online tools available where parents themselves can go and log in, and they can see that what is the risk factor for the patient. So they just need to fill all the forms, all the history about the children, the parents, and they themselves will come to know that, yeah, my children is in the high risk factor. So once they found and once they understood that their children is in the high risk factor, then of course they are already motivated. So now they know that, oh, now I need a myopia control option. Once they come to you with this thing, or you counsel the parents with all these tools, then once they're motivated, then your job is to understand that how we should proceed. We should go directly with the orthokeratology lens, or we need to see that is there any requirement of binocular management. binocular visual management. So these all needs to be understood, and then of course with all these things we can have a better result.
Roughly, when will we start seeing the results with ortho-K lenses?
Sir, I think yeah, 6 months. In 6 months you can actually able to understand that yes, results are good, because if you see like one diopter, then if it's not increasing by 0.5 diopter in 6 months, then of course you can easily make it out that yes, we are getting a better results.
And in terms of refractive correction, how long will it take?
It takes 2 days, sir. Again, depending on the power. If the power is very low, like 0.5 means 2 diopter, 3 diopter, then of course you can get in one day, one night only. They can have 6/6 vision. But as I mentioned, this 6/6 vision will not for a long hours in the initial days. So if you talk about the means everything final, then in a week they will have 12 to 13 hours of vision correction, 6/6 vision with a better myopic due focus. With a 7 days follow-up. So within 7 days, everything will be perfect for even for a high diopter also.
Thank you.
Thank you, sir. Next question is, please comment on the relation with various myopia control lenses and good corneal thickness, and also about possible keratoconus progression control. Vinay sir, can you add on this?
Well, I'm not sure whether ortho-K can control keratoconus progression. It's an entirely different, pathological mechanism.
It doesn't, sir.
Yeah.
It doesn't.
Yeah. Various myopia control lenses. Practically, I have no experience with any of these myopia control lenses.
Sir, orthokeratology. Sorry, sir. Orthokeratology can't control my keratoconus. That is for sure. But it can correct some mild keratoconus. That is possible. You can correct that. What I mean to say that you don't have to go for scleral contact lenses. Right, sir. Refractive, only refractive, no control.
Right.
Thank you, sir. So for orthokeratology treatment, before starting it, does we take consent from the patient, a written consent from the patient?
Very much, very much.
Parents,
that is one of the criteria in our this.
Yeah.
We have in our protocol. So that is a very important criteria. So we have one last question. Is there any minimum age to start with orthokeratology lenses?
As per FDA, it's 7 years, but we have done 5 years also in India. But FDA is 7 to 14 years for myopia control.
So we have come to the end of our discussion part.
I have one small question. With ortho-K lenses, what is the quality of vision? Does it affect aberrations? Does it affect the contrast sensitivity? Any of those things?
Sir, quality wise, it will be not as good as monofocal correction. That is for sure, because just like LASIK, sir, because in LASIK also we are doing the same thing in different way. We are creating a flap and then we are giving a mid peripheral stiffening in the cornea. That is happening. Dimpening, we are doing dimpening. So the same, if you want to correlate the quality of vision with orthokeratology, it is just like a LASIK treatment. But of course there will be no dryness. But yeah, quality of vision will be like LASIK, not like monofocal correction or spectacle RGP correction.
Thank you.
Thank you everyone for your answers on the comment sections. So we can move on to the next lecture. This session will be handled by Dr. Vinay S. Pillai, Senior Consultant, HOD of Cornea and Refractive Surgeries, Giridhar Eye Institute. His area of interest is in ocular surface disorders and corneal stem cells, keratoprosthesis and other corneal disorders, high-risk corneal transplant and pediatric corneal disorders. He has also participated, presented, and has taken lectures on scientific topics in international and national conferences. I welcome you, sir, for the session.
Thank you. Thank you for having me here, and welcome everybody once again to this wonderful meeting organized by Giridhar Eye Institute's Ophthalmology Department. Now, as you have seen in the previous talk and all, One of the major, factor required for assessment of the cornea before any of these specialty contact lens is given or used is to assess the corneal topography or the surface of the cornea. I mean, how do you measure the corneal topography? I'm sorry. Yeah, hope I'm audible enough. So these are the various techniques which are available. The simplest thing is the keratometry. Then came the Placido systems or Placido discs. Over a time, there have been, improvement in various techniques, and what has actually, caught on now or widely available is the Scheimpflug camera system, which gives excellent images. And what has actually changed is from topography, it has moved on to something called as tomography, which gives information about the whole anterior segment and not just the anterior surface of the cornea. So what does these machines measure? They measure various aspects to give an idea about the shape of the cornea. The radius of the curvature is one aspect, then the power of the cornea, and then the height. So what are the applications? Basically, more commonly used in screening corneal, or ocular disorders like ectatic disorders like keratoconus, PMD, or even contact lens warpage. It's refractive surgery pre and post, same in corneal surgeries too. If you are suspecting any cause of irregular astigmatism, in post-surgery suture removal or manipulation to get a smooth corneal surface, in very irregular cornea for IOL purpose calculation, this helps. And of course, today's topic in contact lens fitting, especially in special cases. Most common is for surgery, refractive surgery and corneal ectasia. These are the various machines available, and what I have access is to what is called as Oculizer, which is actually a pentacam with a little software modification. So most of the discussion will be based on this machine, but then the basic principles in understanding any corneal topography is the same. Now, this is the most common picture which you see in most of the machine printers. This is called as a quad map. And when you see this, what are the things that you look for? The first thing to look for is the demographic. Is the investigation which you have is of the correct patient eye, when was it done, what type of machine was used, and then one other important factor is the quality of the examination. I'll come to that later. Then you can see multicolored picture. What does these colors mean? If it is in the green or yellow zone, it means you are in the safe zone. But if it is hotter colors, it basically means like the red signal stop. It may not be normal. Relook deeper into these areas. And the cooler colors means it is a flatter or a lower in a curvature map. So if you see this picture and if you see the colors, you see bizarre arrangement of color, very steep areas here, very flat areas here. So is this really irregular? Is this abnormal? But then before you really assess that, look at what is called as a QS in Pentacam and Oculizer, which is a quality indicator. It is in red. You don't have to actually see what is written here. That is the advantage of Oculizer and Pentacam. It is flagged, color flagged. If there are no colors, it is normal. If there is red, it is abnormal, absolutely abnormal, and doubtful is yellow one. Now look at this picture here and look at the time here and see what has happened. This is after a blink. Okay, the whole surface is smooth and the quality has become normal and it looks much, much, much better, right? So that is one of the first things which you have to assess when you see a picture. Now going to interpretation of maps per se. When you are given a map like this, what are the things to look for? You have to see what each picture means. The first thing to look at is the curvature map. Okay, when you see curvature, it means how much of the surface is curved or what is the dioptric power of the corneal surface. There will be numerical values given along with that. So look at this. And in this curvature map, what is to be looked at? Now, simply putting it, any topography is a study of symmetry. Okay, how symmetrical is the map? Symmetry between the upper half and the lower half of the curvature map. If you look here, it is practically very symmetrical in the upper part and lower part. Or symmetrical topography means it is practically a normal topo. Okay, then look at the values. You can see the same case here. The astigmatism is very normal. Then there is a K-max, which is the steepest point on the surface. All those are with the normal limits. So this is the second part to look at. First symmetry, then look at the values. Now, what is a, but before going into that, one very important thing to look at is what is the scale used. Commonly used is absolute scale, which means that one color always indicates one curvature. For example, here the yellow means 45 in all prints with the absolute scale. Yellow will be 45, but then normalized scale is different. You can see it's the same picture with different scales. So normalized scale is not routinely used because it is very difficult to understand and it is difficult to compare. So look at the scale and then look at the symmetry and the pattern. You know about the bow tie. The common is what is called as the symmetrical bow tie, then round, oval, symmetric, irregular. What are this? This is actually a round pattern, then oval pattern of the anterior surface. This is symmetrical bow tie. This is actually a placido disc, and this is a pentacam one. This is Schimfleck based. So this is a symmetrical bow tie, and this is an inferior steepening and a symmetrical bow tie with superior steepening. Just to get you, to understand what is meant by the patterns. And this is terribly irregular anterior surface. You can see how irregular the placido strings are in this picture. So these are some of the patterns you see. Now, once you look at the, this picture, curvature picture, the next thing to look is how does it compare with the other eye? If you see here, this is the right eye picture and this is the left eye picture. What do you see? The left eye looks like a mirror image of the other, right? So again, this is a normal feature and this is called as enantiomorphism. Okay, these are the small points which help you in saying that this might be a normal topo and there is no abnormality. Next thing in a tomography is to look at the pachymetry map. Okay, so it usually has a dome shape from thin to thin, peripheral thickening, and you have the absolute values here and where is the location. So look at the thinnest point, it is 552. Anything above 500 for for the sake of discussion can be considered as normal, and anything below that should always raise a red flag. Now the next two maps are called as elevation maps. It's a little difficult to understand the concept of elevation. It actually means how much the cornea surface is elevated above a surface of reference. Now, how do you get this reference surface? The computer calculates it from the value of that particular corneal surface. It calculates a surface which actually fits best into that cornea. And then how much above this arbitrary surface is a 1 point or how much below it is. So this is a normal one. This is why I say it's normal, because this is a kind of hourglass pattern. This green areas means this is where the best fit sphere actually touches the surface of the cornea. The yellow, the blue areas of the coolest colors indicate what are the areas which are below the surface, and the warmer areas means points which are above the surface. Okay. So this is a another printout from the packing map. From the oculi. It's slightly difficult again to get the concept of this thing. What it does is it actually removes the central steepest area 3 millimeter and then calculates and best fit spheres to give the final output. So basically you have to understand that if it is green here, it is normal. If there is any yellow round in the lower picture, there is a suspicious of abnormality, and if this is red, the cornea being abnormal cornea is very high. And these lines are important because this is red line is what is the cornea, and the other three are normative data. So the red line should follow these dotted lines. If there is any abnormality or any sharp fall or raise, it is an abnormal cornea. What it means is that or what it denotes is from the thinnest point, how fast the cornea is thickening towards the periphery. That is another value of normative value, which you have to consider. And finally, this is the D value, again, a statistical indices. You don't have to remember the number. If it is yellow, suspicious, red, abnormal. So this is in nutshell how to read a topo. Now let's go to another case here. Now, if you see this picture, what is the first thing you do? Look at the patient. Okay, forget that, you have done that. The next thing is QS, quality. Says okay, fine. Then come to the curvature map. What is the first thing you do when there is a curvature map? Is the color, any hotter colors there? No. Then look at the upper half and the lower half. How symmetrical are they? In this one, it is quite symmetrical. Look at the values here. How much is astigmatism? Not much. Okay, how much steep is the cornea? 45. So this probably, and what is the shape here? It is a symmetrical, dumbbell shape. So probably this is a normal anterior curvature. Next, look at the Pachy map. I mean, again, colors are normal. What is the thinnest? 530. Well, good cornea. And curvature, it is normal shape. The hourglass pattern in anterior and posterior elevation. So this is a normal topography, and again, this also is absolutely normal. We won't give much importance to this printout. Now look at this example. Quality is good, but then see at the center there is some hot color. So is it abnormal? What is the symmetry? Not much of a symmetry, slight superior steepening or superior widening of the dumbbell here. But then if you see the absolute values here, at the 5 millimeter zone, it is 44.4 and 45.5. Just about 1 diopter difference, practically normal. Mild steepening here, but astigmatism is also not very high. Steepest cornea, 45.9, 46, reasonably okay steepness. Probably it is normal. Now look at the Pachy map, quite thick cornea. Thinness is 598. And what is the elevation? Hourglass pattern, slightly broken hourglass, but then it is normal. Okay, again, bad display is also normal. So this is another normal print. Now look at this patient, for instance. How will you read this? Quality good. How is colors good? How is the symmetry good? Pattern, symmetric dumbbell. So this is practically normal curvature, but then look at the thickness. How thick is the cornea? There is, there is redness there. Okay, so yes, it's a warning sign. Thinnest point here is 467, quite thin cornea, right? Now look at the elevation map, practically normal here. So is this abnormal? Is this, when you see thinning of the cornea, what do you think? Is it keratoconus? Well, there is no definite evidence from this picture to say that this is keratoconus other than the cornea being thin. So next comes the importance of this display. Again, this is also normal. So is this a normal cornea? With that single image picture, single eye picture, we would say probably this is a normal cornea, but thin. And look at the other eye. What do you see? It is actually the mirror image. Enantiomorphism is there. So we can brand this as a normal but thin cornea. Okay, the only problem is this eye may not be suitable for any refractive surgery purposes. Other than that, this is a normal cornea. Now look at this. Good quality but red print. Okay, very steep cornea. So is it normal or is it abnormal? How symmetrical is this? Very symmetrical, almost symmetrical dumbbell. Very steep cornea. Astigmatism is quite high. So is this keratoconus? Look at the Pachy map. Quite thin cornea, thick cornea. Thinness is 540. Again, look at the posterior and anterior and posterior elevation. Quite normal. So is this a keratoconus? Again, with this picture, it is difficult to say. With this, just a quad map, we can brand it as normal, but we should always look for further other indicators. Here also, the bad display is also, all parameters are within normal except that, Kmax is flagged because it's quite thick, quite steep. Otherwise, it is a normal steep cornea. It is not keratoconus. Now, look at this one. Quality good, How is the symmetry? Quite asymmetric, right? The upper part is greenish yellow, lower part is more yellowish, more steeper. Look at the 5 millimeter number here, 41.5, and here 43.5. There is a 2 diopter steepening on the inferior aspect. Now, you would have heard about the criteria of Rabinowitz for diagnosis. What does it say? An inferior steepening of more than 1.4 to 1.5 is a factor favoring keratoconus. But how steep is the cornea? Practically normal, case here. The steepest is 43.6 only. But there is a significant inferior steepening. Look at the pachy here, normal. Elevation, reasonably normal. There is nothing abnormal here, except that there is a central isle, what is called as a localized area of elevation in the anterior part and low posterior part. But anything below 12 here and 18 here is considered normal. So from this quad map, we may say this is normal, but then before we brand, look at the other factors. Again, here also it is normal, except for this, which is little suspicious. But then seeing this eye, we may say this might be a normal cornea. Well, we cannot advise a refractive surgery, we will wait. Again, before we brand one eye normal, always compare it with the other eye. So what is the second eye picture? This is the picture. Very steep cornea, highly, irregular surface, and asymmetrical surface, severe steepening inferiorly. Then if you can see, the steep axis is quite, there is a V shape, which is called as skewing of the steeper axis. So this is quite abnormal, and this is classic of keratoconus. Look at the thickness. How thick is it? 487. Now look at the elevation. There is a localized elevation which is more than 36 microns here, and look at the posterior elevation, more than 69 local central island. This is classic keratoconus feature. So one eye has, keratoconus, and the other eye some features, but then no. What do you brand it as? It is a suspect keratoconus, or probably you can say it's FFKC. Terminology is controversial here, but then that is definitely a suspicious of keratoconus in the right eye. So frank keratoconus in one eye and suspect in the other eye. Now look at this picture. Again, good quality. How symmetrical is it? Very symmetrical, but steeper in the horizontal axis against the rule. Good corneal thickness. So is it normal? Look at the elevation. What do you see? Very high elevation, localized island in the posterior surface. So what does this mean? Is it normal? No, this is definitely abnormal, but rest all pictures are normal. So what do you call this as? Look at the bad display, Bellin ambulatory display. There is a red circle here. That means the posterior elevation is definitely abnormal. So this is what may be called as subclinical keratoconus. There is no, even if you do your refraction, you will not get any scissoring here. There will not be any clinical features, but only in topo or tomography you get features suggestive of keratoconus. Now, what is this? Severe against the rule astigmatism, or what is called as crapped claw. Inferior part, this white area means there is no data capture. Why is that? Look at the shape of the cornea. Very irregular here. Peripheral thinning. This is classic pellucid marginal degeneration. But not all crapped claws are pellucid marginal degeneration. Look at other printouts also. There is central thinning, periphery is okay. Again, central steepening only. So this means this is a keratoconus which has got a pellucid-like picture. And this picture, again, quality not really good, but look at the map, very irregular. In conditions like this, you take multiple times, okay, to make sure that this quality can be affected because of the tear film, because of problem in taking, and again in conditions where the surface is very irregular. So that is where you have to that is why you have to take multiple pictures to make sure that your technique and the corneal surface is not affected by the tear film irregularity. So this is a highly irregular cornea, and this is how an irregular astigmatism looks like on topography. Now, this is the picture. It's actually DALK after suture removal. You can see there is significant change in the irregularity here, some amount of smoothening. And this is the difference picture, which shows post-suture removal, pre-suture removal, and how much of flattening in the horizontal axis has happened after suture removal. These are called difference maps, useful in conditions like this. And again, this is post-myopic LASIK, which shows significant flattening in the center. This is after topo-guided PRK-CXL, the change in topography. So difference maps are other kind of printouts which you can use in various conditions to give an outline or to understand what is the change happening from one point of time to the next point of time. I think I'll stop with that. Thank you. And probably we can take questions if there are any.
Thank you, sir. It is really a useful section. Stepping to the next section, contact lens option in keratoconus, and it will be handled by Ms. Parvati, Faculty Assistant to the School of Optometry and Visual Sciences. Moving to you, ma'am.
We can have a discussion after the end of the session, so feel free to ask any questions in the chat box.
So, good morning, everyone. Myself, Parvati Ara, faculty from Sushrita School of Optometry, Giridhara Institute. So today I'm going to discuss about the contact lens options in keratoconus. So when considering the fitting process of keratoconus, we need to consider cone position, cone size and shape, degree of myopia, corneal astigmatism, corneal radius, corneal toricity, corneal eccentricity value, corneal topography, disease progression, degree of progression, rate of progression, then visual acuity, and contact lens tolerance. So coming into the fitting options, first of all, we consider thick toric soft contact lenses, which are rarely used. And second one is silicone hydrogel materials, examples Kerasoft, IC, Bosch and Long. Then piggyback contact lens system, hybrid lens, contact lenses, and scleral contact lenses. So first one, fitting soft contact lenses. We usually accept this in the early stage of progression or in case of gas permeable contact lens intolerance, and usually in this case the astigmatic component is corrected with over spectacles. The other option in soft contact lens is soft K-cone. So they are double lenticulated lenses with structural stabilizing ring and two pressure balancing fenestrations are included. So they are made with definitive silicone hydrogel material. Next is Kerasoft IC or Arc Optical or Bosch and Long. So they have a BOZR of range from 7.4 to 9.4 mm in 0.20 step increasing, and total diameter 14.5 mm in 0.50 steps, and lens designs are available in aspheric as well as prism ballast. Then power range start since sphere as plus 20 diopter to minus 20 diopter, cylinder as minus 0.50 diopter to minus 12 diopter, axis 1 degree to 180 degree in 1 degree step increment. Then material which I used is definitely material or silicon hydrogel. Next is piggyback contact lens. So piggyback contact lens act as a carrier, that is soft lens act as a carrier overlying gas permeable contact lens. So usually ultra thin disposable lenses are used for this purpose, and this piggyback contact lens option is used to increase the comfort and reduce the risk of epithelial aberration by a glass permeable contact lens. And it is more complicated because care and maintenance is required for two material types, and overall oxygen transmissibility is reduced since silicon hydrogel offers advantage as the carrier contact lens. Next, piggyback contact lens design. The soft carrier designs comes in total diameter of range starting from 12.5 to 14.5 mm diameter. Central thickness of about 0.10 mm. Countersink is about 8 to 9.8 mm diameter, and PVP is available as plano. In optic or rigid carrier consists of a total diameter of 8 to 9.8 mm. BVP is available from -3 to -15 point diopter, and tri-curve designs are available also. Next is hybrid contact lens. So hybrid contact lens act as a soft and rigid design which combine to form a true one-piece contact lens. So it is suitable for early to moderate keratoconus cases, and only limited parameters are available, and they have relatively poor oxygen transmissibility due to low decay materials. So this is the picture of hybrid lens in situ. Next is an option in hybrid contact lens is clear cone. So the peculiarity of clear cone is the new hybrid skirt design lands inside the limbus and extends onto the sclera. It provides an optimized lacrimal lens or tear lens, and it, despite the location of cone, the visual axis is centered to optic axis, and wall design clears the vast majority of ectasias without bearing. So clear cone is available in 11 different walls, 3 of which can be ordered in 3 different skirt curvatures, that is flat, medium, and steep. The fit of the wall is independent of the fit of the skirt curve. Each should be fitted separately. So coming into the detail, clear cone is available in DK of 100 and water content 27%, diameter 14.5 mm, vault 100 to 600, skirt curvature steep, medium, or flat. Sphere power +2 to -8 diopters, -8.5 to -15 diopters, +2.50 to +5. Then wearing indications is usually prescribed as daily wear, and replacement schedule is recommended for 6 months, and lens care is taken over by hydrogen peroxide disinfection. Next option is synergize. That is, they have high decay center and low decay skirt. Due to that, advanced silicon hydrogel material provide high oxygen permeability, and they actually compromise corneas to minimize corneal stress, and they have a patent reverse geometry vaulted design clears the vast majority of ectasia without bearing, and optimized tear lens and optic center over visual axis is also provided. So this is the first hybrid contact lens with a high decay silicon hydrogel skirt designed for specialized. And it also promotes eye health while giving you irregular cornea, keratoconus, and ectasia patients an unprecedented combination of superior vision and all-day comfort. So when comparing the clear cone with ultra health, the GP characteristics, the refractive index is mostly common, same for both, and modulus is 1150 for clear cone and 1314 for ultra health. The luminous transmittance is greater than 90% for clear cone and 87% for ultra health. UVA transmittance is 18% for ultra health. UVB transmittance is 3.3%. Wetting angle is 42 degree for clear cone and 34 degree for ultra health. Specific gravity 1.10 for ultra health, it is 1.15, and TK 100 for clear cone and 130 for ultra health. Now comparing the soft skirt characteristics of clear cone and ultra health. The material is made up of HEMA in clear cone and in ultra health silicon hydrogel. Modulus 0.7 to 0.8. And comparing with ultra health, it is 0.5 to 0.8. Luminous transmittance is 95% in clear cone and 97% in ultra health. Wetting angle in ultra health is 25 to 35 degree. Decay is 9.3 in clear cone and 84 in ultra health. Water content is 27% in clear cone and in ultra health it is 32%. So this is the picture of different designs of Synerge eyes in situ. So B indicates the base curve based design and C indicates the clear cone design and D indicates the hybrid, ultra health hybrid lenses in the eye. Last but not the least, the scleral contact lenses. They are the last option for advanced keratoconus cases. So it is ideal for intolerant rigid contact lens wearers regardless of the stage of the disease, and it helps to delay or avoid the need for corneal surgery. So this is the picture of scleral contact lens in situ. Thank you.
Thank you, ma'am. Without any further delay, let's move on to our next session on visual performance and comfort with rose scale lens for keratoconus, handled by Ms. Jesla RV, optometrist, Giridhar Eye Institute. People who are streaming live in our YouTube, drop your doubts in the comment section. Participants, feel free to ask your questions in the chat box, which will be discussed at the end of the sessions.
Good morning, everyone. Today I'm going to take the topic on visual performance and comfort with rose-key lens for keratoconus. Myself, Jesla RV, optometrist at Giridhar Eye Institute. What is a rose-key lens? A highly breathable design in which the polymers used allow oxygen to penetrate directly through the lens that reliably corrects refractive error, be it astigmatism, myopia, or hyperopia associated with keratoconus. The rose-key lens closely mimics the cone shape of the cornea for every stage of corneal condition. Its complex geometry can customize to suit each eye, thereby maintain good corneal health and maximize vision by setting the optic zone. What is the principle behind the rose-key lens? For each base curve that respects the apex of the cone and unique axial edge lift will be associated to it. That is a unique optic zone and a unique peripheral curve. This is the image that's showing a standard lens design, which has a larger optic zone with a deep pooling and lens optic zone optimized for the cornea size. Always the axial edge lift will be closer to the cornea. What are the historical milestones and rose-key lens? It was invented by Mr. Paul Rose, an optometrist from Hamilton, New Zealand in 1987. After testing 700 lenses and 12 different designs, he produced a set of 26 lenses from which all patients could be fitted. In 1990, he launched rose-key lens in New Zealand market, and in 1995, he gained approval from US Food and Drug Administration for sale in America. The major features of rose-key lenses: it is easy to fit using a simple systematic approach, and a simple and flexible edge lift system is available. Good aberration control, which act as aspheric optics, providing outstanding visual acuity, thereby reducing glare and flare. And the other feature is a minimum lens mass. Now let's discuss about the rose-key family of design. There are several designs in rose-key family. The first one is rose-key 2, and the second one is rose-key NC, that is for nipple cones, and rose-key IC, that is for irregular cornea. Rosque 2 PG, that is for Rosque 2 XL and the Rosque 2 XL. The Rosque 2 lenses are unique geometrically designed contact lens. The design goal of the Rosque 2 is to bring all focal points onto the retina at a single point, regardless of base curve, radii, or lens power, incorporate a specific eccentricity value in back optic zone. Then stretching the optic zone without changing the fit to create the desired results in improved vision and comfort. Now let's discuss each one of the designs. The first one is Rosque 2. It has a multi-spherical posterior design, the front surface aberration control that provides a superior vision. And in Rosque 2 NC, that is for nipple cones, it is used for moderate, advanced, and any defined nipple cones. There is small aspheric back optic zone diameter that decreases as the base curve steepens. The rapid peripheral flattening from the back optic zone is very useful in this fitting of the Rosque 2 MC. In case of Rosque 2 IC, it is for larger areas of corneal distortion. The larger overall diameter, same as the Rosque 2 systematic fitting approach. In the Rosque 2 post graft, that is PG, it is designed for post-operative recovery and for improvement in vision. It has multi-spherical posterior design with reverse curve geometry. The aberration control aspheric optics across the front and back optic zone radius. Rosque 2 XL, it is the same as semiscleral design that provides stability and improved comfort in poor tolerance to corneal diameter lenses. It rests entirely on the cornea, just inside the limbus, and lifts over the sclera. Now let's move on to the topic, the indications of the Rosque 2 lenses. There are primary and secondary indication. In case of Rosque 2, it is oval keratoconus. The primary indication is it can be used for oval keratoconus. The secondary indication is early nipple cones. In the case of Rosque 2 NC, it is used for nipple cones and advanced oval cones. In the case of Rosque 2 PG, it is used for post-graft corneas, you know that, and the descended large oval cones, any post-corneal surgery, example LASIK or penetrating keratoplasty. In the case of Rosque 2 IC, it can be used for PMD, that is pellucid marginal degeneration, keratoglobus or LASIK-induced ectasia post-graft, and also highly descended oval cones. In the case of Rosque 2 XL, it is used for KC, PMD or post-graft, post-LASIK ectasia, post-surgical or advanced dry eye or corneal ring. The secondary indication of Rosque 2 XL is it is used for stability for sport or working environment or corneal GP intolerance, or in the case of piggyback. These are the images of cone types that is taken by a topographer. The first one is nipple cone. You can see the image. Centrally, there is a strip or hot color. So the recommended design in nipple cone, it is Rosque 2, Rosque, and Rosque 2 IC. In the case of large oval cone, you can see the image right here. The recommended design is Rosque 2, Rosque, and Rosque 2 IC, which is greater than 9.5 mm. And the pellucid marginal degeneration, the recommended design is Rosque 2 IC, Rosque 2 postgraft. And in case of keratoglobus, the Rosque 2 IC and Rosque 2 postgraft is also used. In LASIK-induced ectasia, the recommended design is Rosque 2 IC and Rosque 2 postgraft. And all this Rosque 2 IC, that is for irregular cornea, is commonly used. Now let's discuss about the parameter range of Rosque 2 lenses. There are several parameter range in base curve and diameter, also in the edge lift system. So the base curve of Rosque 2 and Rosque 2 NC range from 4.2 to 8.10 mm. In the diameter range, it is about 7.5 to 11 mm in the case of Rosque 2, and in Rosque 2 NC, it is 7.6 to 10 mm. The edge lift of Rosque 2 NC and Rosque 2, there is standard steep fit, standard flat fit, and also standard. More lifts are also available. We can choose it in a way of 0.5 step. Okay. Then Rosque 2 IC and Rosque 2 PG. Their base curve range starts from 5.2 mm to 12 mm, and the diameter range is about 9 to 12.5 mm. In this too, we have a standard, double standard flat and double steep. More lifts are also available in 0.5 increments. In the case of rose K2 XL, it is available in 5.6 to 9.6 mm, and also the largest diameter like 13 to 16.6 mm. Okay, the power range is available up to plus 40 to minus 40, and 21 options are available in 0.56. The power varies with the material. In case of rose K2 or rose K2 NC, power always varies with the material. This is the illustration of available edge lift. In the case of rose K2 and rose K2 NC, 85% of all rose K2 lenses utilizes either a standard or standard flat or standard steep edge lift values. Okay. The minimum flat lift is about plus 3 in rose K2 lenses, and maximum steep lift is minus 1.3 in rose K2 lenses. In the case of rose K2 NC, the maximum flat lift is about plus 4 and maximum steep lift is about minus 1.3. In the case of rose K2 IC and PG, edge lift from plus 3 to minus 3 are available that we can fit for all the patients. The maximum flat lift is plus 3, which is showing in the figure, and maximum steep lift is minus 3. Now let's talk about the flexible edge lift system. The peripheral fit is the single most important fitting factor for a successful and comfortable GP fit. And it is always important that the peripheral fit and the central fit is mainly considering while we are using the flexible edge lift system. The all rose K2 lenses use a symbol value referred to as edge lift to determine the optimal peripheral configuration. After assessment, a comprehensive range of edge lifts are offered to provide the optimum amount of edge lift clearance. The final lens is always automatically compensated, and when we change the edge lift, it does not affect the central fit. These are the image showing the optimal edge lift. In case of an optimal case, the fluorescein band is up to 0.5 to 0.7 mm with no excessive lift or peripheral seal at any point. This is the first image showing optimal edge lift. And when the fluorescein pattern indicates edge lift in excess of 0.5 mm to 0.7 mm, we need to choose a standard steep edge lift value in this case. Okay, when the fluorescein pattern indicates an edge lift less than 0.5 mm to 0.7 mm, then the standard flat edge lift value is recommended in this case. There are also more options for rose K2 lens. The advanced fitting options involve toric peripheral curves, asymmetric corneal technology, front, back, and bi-toric designs, quadrant-specific edge lift. In this case, extensive diameter and base curve ranges are available, and it fits most corneal shape, size, and stages of keratoconus because of its unique design. When you are starting to do a trial, we need to use a diagnostic lens. That is the only way to properly assess the correct fit and final lens power. You can use topical corneal anesthetic when you are assessing. If it is a new patient, better to do with the anesthetic drops. Otherwise, you can start without anesthetics. When selecting the initial base curve, keep in mind that the keratometer only measures the central 3 mm along the line of sight. So your first trial lens may not yield the best fit. So we need to do 2 or 3 trials. So determine the appropriate rose K2 design for the corneal condition to be treated. That is the main point. According to the Pendicam report, we can select the design, which rose K2 design is appropriate for that condition. The fitting overview involves step 1 is for base curve selection. Select the base curve that yields a central fit appropriate for the design. The step 2 is peripheral fit. Adjust the periphery to yield an even fluorescein band 0.5 mm to 0.7 mm width. In step 3, the diameter is considered. Select the minimum diameter that yields good location and movement. In step 4, the location. Adjust parameters such that the lens hang off the top lid and is well clear for the lower limbus. In the step 5, the movement is noted. Adjust parameters to achieve movements on blink of 1 mm to 1.5 mm. Now let's see a brief case that presented in our clinic. A female with 28 years old. The purpose of visit was second opinion for cornea, and her main complaint was blurring of vision since 2 weeks, and consulted elsewhere, advised to C3R, came here for a detailed evaluation and further management. The ocular history revealed that she is a known case of keratoconus patient with from last 1 year, and no history of glasses or contact lens, no other family history or allergic history. The ocular examination shows that her uncorrected visual acuity in right eye is 660 and left eye it is 624. Both the eyes shows a dull and scissoring reflex while doing the retinoscopy. The acceptance in right eye, they both done with trial and error method. In right eye, it is -3 sphere with -2 still at 150. And in left eye, it is -2 with -2.5, 2.25 diopter still at 160. And the best corrected visual acuity with the lenses, it is in right eye, it is 618 N6 and in left eye, it is 612 N6. This is the K reading of that patient. On slit lamp examination, noted prominent corneal nerves, thinning, Vogt striae and Fleischer's ring. Obviously, they are the signs for a keratoconus patient, and consulted the doctor, and action plan was contact lens trial and review after 6 months for Pendicam and evaluation on progression of KC, then to decide on C3R. This is the Pendicam report of that patient. The right eye shows a steepening in the lower area, like the base curve is 7.59 and the minimum maximum base curve it is 7.19. This is the left eye Pendicam report. Patient came for the follow-up for contact lens trial. The trial done with RGP contact lens, which is a spherical RGP from Purecon brand. OD is corrected with a 7.5 base and diameter of 10.50 with -5 power. And in left eye, we use the trial 7.90 base curve, diameter about 10.5 and -5 power, the 100 DK lens. On the fit assessment, on the right eye, there was a slight edge lift and there is an apical test. Still, it is not that much good fit. And in the left eye, it is okay. With overcorrection of plus 0.75 in right eye, the vision improved to 6.9 N6, and in left eye plus 2.25, the vision improved to 6.9 N6. After the trial, the patient presented with complaint of irritation, watering, and photophobia with RGP lens, and vision also not improved even after alteration in base curve and diameter. So we advised for Rosquet-2 trial in next visit, and she came for Rosquet-2 trial after 2 weeks, and we have done trial with 7.7 base curve in right eye and diameter 11.20 with -6 power, and we taken the standard edge lift lens. The fit assessment was optimal. We have done 2-3 trials. After that, we have came to this final prescription, and the left eye OS 7.80 base curve and diameter 11.20. There is an optimal fit in the left eye too. With overcorrection, the vision improved to 6.6 N6 in both eyes, and the final prescription is shown here. We have chose the lens Rosquet-2 IC for irregular corneas that we can use for this kind of keratoconus, and the vision improved and comfort of the patient also improved. Patient was very happy and satisfied, and she insisted for Rosquet-2 IC in left eye also, and advised follow-up after 2 weeks with the lens on. Finally, when we are talking about the advantages of Rosquet-2, a smart design process that uses complex computer operations and special digital aids to craft each lens to the perfect shape to suit the patient. A highly breathable design. Rosquet-2 has a highly breathable design that allows oxygen to penetrate directly through the lens. Whether the condition is mild or advanced, Rosquet lens can provide powerful vision correction. The other one is the option for customization. It can be custom designed for any eye by matching the specific corneal irregularity of the patient that we have discussed just before. Their ease of use. Rosquet lenses are easy to insert, remove, clean, and care for. Compared to RGP lens, the success rate was very much higher in the case of Rosquet-2 lens. The Rosquet-2 lenses are a viable alternative in the visual rehabilitation of patients with the keratoconus in case of their comfort or vision. So Rosquet lens plays an important role in patients with keratoconus. And that is the end of the session. Thank you.
Thank you, Ms. Desla. Since we haven't received any questions in the YouTube comment section as well as in our chat box, We are moving to the next section, beyond the corneal borders, and it will be handled by Ms. Taslima, optometrist of Giridhar Eye Institute. Moving to you, ma'am.
Good afternoon all. Here I am briefly talking about some basic aspects of scleral contact lenses. First of all, what are scleral contact lenses? Scleral contact lenses are large diameter GP contact lens that rest beyond the limits of cornea and extend onto the sclera. It traps a lot of fluid reservoir between posterior surface of the lens and anterior surface of the cornea. It has unique fitting and aftercare characteristics. The Scleral Lens Education Society introduced an internationally recognized nomenclature for describing scleral lenses based on its resting area on ocular surface. A lens that completely rests on the cornea is called as corneal lenses. A lens that partly rests on the cornea and partly on the sclera is called as corneoscleral lenses. And a lens that completely rests on the sclera is scleral lenses. It is again subdivided into mini scleral lenses and large scleral lenses. A lens with a diameter up to 6 mm larger than HVAD is mini scleral lenses. More than 6 mm larger than HVAD is large scleral lenses. Usually, corneal design has diameter range between 8 to 12.5. For corneal scleral lenses, it is 12.6 to 15 mm. And mini scleral lenses usually have diameter range between 15 to 17.9 mm. Large scale lenses are larger than 18 mm in diameter. Then coming to historical milestones, the scleral contact lens was first described in medical literature, and in late 80s researchers in Germany developed and started using blown glass shell for the treatment of keratoconus. They are completely impermeable to oxygen and very difficult to manufacture and not easily reproducible. Later in 900s, reintroduced in the advent of PMMA material. PMMA is also impermeable to oxygen, and they have used impression mold technique for this. The developers started making lenses small and fenestrated to allow the tear to flow under the contact lens and increase oxygen. In 1970, clear lens were reintroduced again in RGP materials. By 1990, several milestones were reached with well-defined fitting techniques and technological innovations in the design and manufacturing of lens leading to better performance. Then coming to lens materials, the scleral lens material evolved from PMMA, which has a diffusion coefficient of 0, to currently available high and ultra decay materials. For example, Boston XO, XO2, Menicon, Paragon, etc. And scleral lenses are considerably thicker as compared to GP lenses, usually ranges between 0.4 to 0.6 mm, and it varies, depends on design, and the thickness tends to increase from center to periphery, and a thicker lens would have lower decay, and most of the lenses are plasma treated to increase the wettability. Then how are scleral lenses different? Why do scleral lenses become more popular nowadays? There are some couple of reasons for this. Main reason is comfort. Scleral lenses are secured under the eyelids, which does not rub against cornea and eyelid, and it lands on the bulbar conjunctiva, which is less densely innervated as compared to cornea. And these have a larger diameter, so they are well centered and very stable. So if a patient complaining of frequent pops out of GP lenses, lenses would be a better option for them because it prevents dislodging, and it has a larger optic zone, so it prevents vision from fluctuating. And these lenses are filled with non-preservative salines, so that keep the eye moisturized and lubricated all the day, which increases the wearing time. Then coming to indications, first of all, vision improvement, then ocular surface protection, then sports and cosmetic indication. Scleral lenses are mainly used to improve the vision and corneal irregularities. Corneal irregularities comprises primary corneal ectasia and secondary corneal ectasia. Primary corneal ectasia includes keratoconus, keratoglobus, and pellucidal marginal degeneration. Then secondary corneal ectasia includes post-refractive surgeries such as LASIK, PRK, and RK. And it also includes corneal ectasia resulting from a corneal trauma. Then scleral lenses can also be given for those with high myopia, hypermetropia, and aphakia. Then it has an important role in the management of ocular surface diseases, which includes any disorder of the tear film or abnormality in eyelid structure or function that could result in compromise to the ocular surface. It has a great impact on the management of severe dry eye conditions such as Sjogren syndrome, Stevens-Johnson syndrome, then limbal cell deficiency, ocular cicatricial pemphigoid, persistent epithelial defects, etc. because of the retention of fluid between the lens and the cornea. It also helps in the management of corneal. It also helps to it acts as a protective devices in corneal exposure such as the eyelid coloboma and the corneal nerve pulses. You can see here the first picture. In the first picture, there are significant corneal staining is there before I started wearing clear contact lenses. After 2 months of lens wear, the staining significantly reduced. Here, the scleral lenses can also be given for those with active water sports such as water skiing, water polo, then diving, canoeing, etc. And those with exposure to dusty environment. The printed scleral lens can be given for improving cosmetic appearance in cases such as atrophic bulbae, then to reduce glare in conditions of aniridia and albinism. And cosmetically, scleral lenses can be given for ptosis also. A larger diameter, significantly vaulted scleral lens will increase the aperture size as shown in the picture. This is the picture of a Hollywood actor, Tom Cruise, who you have used scleral lens for protecting his eyes and enable them to open while exposing high-speed wind, as he was hanging on a fighter jet flying 5,000 feet above from the ground. Then, when do you consider scleral contact lenses? Keratoconus patients usually have a high level of toricity. A scleral lens with significantly vaulting on the cornea will correct these irregularities, and these have larger optic zone, so it is particularly important in patients with descended keratoconus and keratoglobus, and for those with complex corneal shapes that resulting from a keratoplastic surgery. These lens would be the first options in nowadays, become the first option in current practices. So because the scale lenses, fitting of scale lenses is comparably easy as compared to other lenses because the scleral lens profile remains same even after the surgery. And some studies shows that many of the patients referred for keratoplasties were successfully fitted with lenses. So it is important to assess how much visual acuity can be improved with available contact lens option, variety of contact lens options, including clearer lens before referring for a corneal transplant. Then coming to lens designs, it consists of optical zone, transition zone, and landing zone. Optical zone is the centermost zone of scleral lenses, and it carries desired optical power. And a front surface may be either spherical or aspheric. This aspheric design helps to reduce aberration to a higher level, and the back surface approximately aligned with the cornea. Then transition zone. The zone between optical zone and landing zone is transition zone, and it is also called as mid-peripheral zone or limbal zone. It determines the sagittal height of the lens. If we are changing the sagittal height of a lens, we are actually changing the transition zone without affecting optical and landing zone. Then finally, landing zone. This is the zone which is also called as scleral zone or haptic zone. It is defined as a flat curve or a series of curves ranging from 13.5 mm to 14.5 mm. The area where the lens rests and align with the anterior ocular surface, that is called a landing zone. Then toric designs. Scleral lenses are also available in toric forms, which includes front toric design, back toric design, and bitoric design. In front toric design, the toric surface is positioned on the front surface of central optical zone to improve visual performance. In back toric design, the landing zone area is made toric to improve lens fit. It does not interfere with central zone. In bitoric design, it combines the fitting characteristics of back toric lens, back toric design with the optical benefits of front toric design. Then coming to disadvantages, the lack of specialist practitioners, then long fitting time, and greater expense and limited availability. That's all about my presentation, and the fitting of the lens will be discussed in the next session by Mr. Swastik. Thank you.
Thank you, Ms. Taslima. We are approaching to the end of our webinar. The last session will be handled by Mr. Swastik, Business Development Manager, V Square Meditech Private Limited. He worked at Karthik Netralaya, Bangalore as consultant optometrist and HOD of Contact Lens Department for 3 years. He also worked with Menicon Resolution as consultant optometrist for Roske and Menicon products, in charge for South Indian division for 3 years. Now joined with V Square Meditech Private Limited as business development manager for Aculens, GOV and Keracare products. Handing over to you, sir. A gentle reminder that we will have a discussion at the end of this session, and feel free to drop your questions in the chat box.
Thank you for the good introduction. Welcoming everyone. This session is all about Keracare scleral lenses. Before I go into the details of fitting the lenses, I would like to introduce Keracare scleral lenses, which is from US. Aculens Laboratories are the ones which designs the lenses. Going into the detail, when we get the patients, when we get keratoconus patients, the first thing what we do the lens is to fit the lenses. Scleral lenses are always the better option. Why? Because it gives the outstanding comfort and the exceptional vision. How do that do? It increase the diameter is very large, and there will be absolutely no movement. It doesn't touches the cornea, and it always walks the cornea. It crosses the limbus, and it doesn't land on the limbus. So few important things before we start going into the fitting of scleral lenses. The very important thing is about clearing the limbus. None of the lenses should land on the limbus. It should go beyond the limbus, because landing on the limbus has its own complications. It can start edema, neovascularizations can happen, keratitis can happen, because the landing zone is on the limbus. The other important thing what we should keep in mind is about the diameter of scleral lenses, which should be minimum 4 mm beyond the HVID. So 2 mm in the nasal side and 2 mm in the temporal side. So the diameter of the corneal lenses has to be decided based on the HVID of the cornea. So it has to be nearly 4 mm beyond the limbus. So we also have a study which says that the scleral lenses are much better compared to the corneoscleral lenses or the miniscleral lenses available in the market. So why is scleral lenses more important? Because it clears the limbus. So the size of the lenses is very, very important. As again told, it should not land on the limbus. And again, it should be not very big because it will be very uncomfortable for the patient. So it can also create conjunctival prolapse and other things.
So sorry for the interruption. I think the slide is not changing.
Okay.
We're still seeing the first slide itself. Now, yes, now the slides are visible.
Yeah. So I'll start from first then.
We were audible. You were audible, but we have been able to see it.
Yeah. So I was talking about this initially. So the diameter of the the diameter of the scleral lens is very, very important because it gives the best comfort and exceptional vision. Clearing the limbus is very, very important. Again, we being a practitioner, none of the lenses should land on the sclera. So the corneoscleral lenses or the miniscleral lenses, which has lesser diameter, lands on the sclera and lands on the limbus. So all the lenses should land on the sclera, creating a vault in the limbus. The minimal scleral diameter, as a study says, is about nearly 4 mm more than the HVID. So it has to be nearly 2 mm to the nasal side and 2 mm to the temporal side. So the diameter of the scleral lens depends on the HVID of the cornea. So it has to be nearly 3.5 to 4 mm more than the HVID. So we also have a study which says the scleral lenses are much, much better when compared to the miniscleral or the corneoscleral lenses in the market for corneal ectasia and dry eye cases. So the size of the cornea, it should be nearly 4 mm beyond the limbus, and it should not be beyond 4 mm also because it might be difficult for the patient to wear and remove the lenses, number one, and it can also create conjunctival prolapse if the lenses are too big. So what makes the corneal fitting, scleral lens fitting very comfortable? One is the proper size. What we aim is for nearly 2 mm.
I'm sorry to interrupt again. Your slides seems to be stuck and you are not in the, full screen mode. Yeah, can you go into the presentation mode, please?
Now it's fine, sir?
No.
Now?
No, actually it has not gone into the presentation mode yet. Probably you can, stop sharing and reshare once more. Yeah, now it's fine. Can you try moving your slide? Just see if it is moving here. No, it has gone out of slide presentation.
I'll try moving.
Yes. Yeah.
Fine now, sir?
Yeah, moving. It's moving. Please do continue.
Yeah. So the size of the scleral lenses is very important. So it should not land on the limbus. It should go beyond the limbus, and it shouldn't be too big also because it can create conjunctival prolapse. So Proper size of the lenses is very important. 2 mm beyond the limbus to the nasal side and to the temporal side. So it has to be nearly 3.5 to 4 mm more than the HVID. The proper vault is very important. Nearly what we aim is for the 150 microns of vault in between the lens and the cornea. The proper edge, which should not blanch or it should not lift. So we don't see movement in scleral lenses. So what does Keracare do? Keracare have toric peripheries where the vertical meridian is steepened and the horizontal meridian is flattened. We also have front surface toric design where toric cylindrical parts can be incorporated. We have something called as limbal curve indicators, which clearly says where the landing zone is. So I'll come in detail to that. Multifocals are also available, the center distance and center near design. We can oblate the design by increasing or decreasing the vault, because all these Keracare scleral lenses are designed with CAD and CAM technologies, where we can technically tell what we require, like 50 microns, increase the vault or decrease the vault, whatever is needed. All these lenses are high definition optic designs, and optic zones can also be altered. All these are on point technology designs where any blanching in the particular meridians can be altered. Like we can also make the changes only at one particular meridian, or quadrant modifications are available, and also a full edge modifications are also available. Hydropec coatings is very important because these are hydrophobic coating which improves the wettability of the lenses, so that the lenses can be worn at a stretch of nearly 10 hours at a stretch regularly every day. So how do we fit the scleral lenses? So initially we start with the lens diameter. We make sure that the lens diameter has to be nearly 2 mm beyond the limbus. Then we select the sag of the lenses. I'll come in detail. Edge of the lenses has to be evaluated. Then the over refraction and centration has to be observed. These are the 5 steps what we see. First is size, which makes sure the diameter of the lenses, sagittal height, the base curve and sag values. The edge of the lenses has to be assessed, and then the over refraction and centration. So this is the trial set what we have, and trial set considers two different diameters, 15.9 and 16.4. These are the available diameters in the trial set. So for moderate and advanced keratoconus, we prefer 15.9 diameter, and for severe keratoconus, we prefer a larger diameter called 16.4. Again, the HVID does matter. For pellucid marginal degenerations, we prefer 15.9, and for post-RK cases or any transplants, we prefer 16.4, little larger diameter. The base curve of the lenses is selected based on the elevation of the cornea. So the moderate and advanced cones, we prefer 7.5 base curve lenses. For more advanced cones, we prefer slightly more sagittal height values. So this is the actual eye, and all the Keracare scleral lenses does come with all these engravings. You can see the engravings here and the engravings here. So the center has grid markings, and the peripheral has something called as LCI, which indicates the landing zone. So initially, we first select the diameter of the lenses. The lens should nearly cross 2 mm beyond the limbus. So again, it depends on the HVID. For smaller corneas, we prefer smaller lenses, and for larger corneas, we prefer larger lenses. We have called as LCI, which is limbal curve indicators. This is how it looks like. So this limbal curve indicators indicates the landing zone of the lenses. So none of these lenses, none of the scleral lenses should land on the limbus. It should go beyond the limbus and land on the sclera. So these LCI indicates the landing zone, which gives the clear picture of the cornea of the scleral lens diameter. So we call it as A, B, and C from the inner side. The A or in between A and B should be the limbus. So when we fit the lenses, we fit the lenses and make sure that the LCI marking is in the temporal quadrant. And in the temporal quadrant, if this is A and the middle one is B and the outer one is C, so the limbus should correlate with A, or it should be in between A and B. This indicates the diameter of the lens is ideal. And as told earlier, so if the limbus is sitting on B, then we increase the diameter. if it is sitting in between B and C, we increase the diameter by 0.5 mm. If it is sitting in C or beyond C, then we increase the lens diameter by 1 mm. So this is how we come to conclusion. Imagine if we have fitted 15.9 diameter lenses, and if the limbus is in between A and B, then the lens diameter is ideal. If the limbus is beyond C, then we increase the diameter by 1 mm and we directly go to 16.9 lenses. It's like that. So this gives the picture of the lens diameter. So the size of the lenses is first evaluated. Next comes the sagittal height. So again, it depends on the elevation. The higher the corneal elevation, we go for higher sag values. Lower the corneal elevation, we go for lower sag values. So assessing the vault is very, very important in scleral lenses. And these are the different pictures of vault. If you see the second line, the first line is the lens, the front surface of the lens, and the second line is the vault. So ideally what we see is for 150 microns of vault once the lenses are settled. So initially when we put the lenses, it will be more, and once after settling, it should be nearly 150 microns of vault in between the lens and the cornea. So as we all know that we fill a saline inside the lenses, and the saline remains there throughout until we remove the lenses, and the saline vault is what we see. So if it is steep, like 600 microns or 500 microns, we go flatter, or if it is flat, like 50 microns, then we go to the steeper side. So how much clearance is required? So when we put the lenses, if the microns is nearly 250 to 300 microns immediately after insertion, then leave it alone. Once the lenses settled after 1 hour, it may reduce to around 150 to 200 microns. So we should see after 1 hour. So the lenses should be settled in the eye for 1 hour, and then we have to reassess the vault, which gives nearly a rough picture of 100 to 150 microns. That is the ideal vault what we see. The third thing is what we see is for the landing zones, which is again saw in the first step itself. So the landing zone, it should not land on the cornea or on the limbus. It should directly go beyond the limbus. So the first picture, if this is the case, the landing zone, if you see, this is on the limbus. So if it is on the limbus or on the cornea, we increase the diameter of the lenses. So make sure that the landing zone is always on the sclera, not on the limbus. So evaluating the edge is the third step. Ideal edge lift is that the blood vessels should clearly pass through the lenses. So if there is an impingement like this, so the blood vessels are stopped there, which creates redness again. So in these cases, we can modify the edges. We increase the diameter, we increase the edges, we flatten them, or we can steepen them. So in the third step, in the third picture there, if it is flatter, we can also steepen them. So this is the ideal edge modification available in ideal alignment, what we aim for. If you see, this is the impingement of the scleral lenses, where we flatten the edge of the lens. And these are the compressions, where we can also flatten the edges or change the diameter. This looks a little larger diameter. We also have something called as on-point technology, where every point of the scleral lenses can be customized. We can modify the edges only at one particular meridian, or we can also modify the vault at only one particular meridian. So anything can be done using these grids and LCI. So as I told, we do the over refraction after assessing the edges, and after over refraction, we make sure that the lenses are centered well. So if the lenses are not centered, it's not only for multifocal lenses, even for single monofocal lenses, we make sure that the lenses are centered well and the optic zone of the lenses are correlating with the pupillary area. If it is not, then we can also ensure, we can ask the laboratory to make the modifications. I'll come to those modifications later. So this is what we aim for. The size of the lenses, it has to be nearly 2 mm beyond the limbus, and coverage has to be absolutely centered well. There should be good proper vault. What we aim is for around 100 to 150 microns of vault once the lenses are settled, and absolutely no movement and no blanching of blood vessels. All these Keratoconus scleral lenses are made up of a technology called CAD and CAM. It's computerized aided design, computerized design. and all these lenses are treated with plasma coating. So any modifications can be addressed. So surface wetting issues is also important when we talk about scleral lenses, because majorly all scleral lenses we prefer to wear them for nearly 4 to 6 hours and remove them, refill the saline, wear them again, which is slightly irritating to the patients. So we Keracare lenses have something called as Hydra Peg coating, which is the hydrophobic coating on the lenses. And all these lenses are made up of Quantamac Extreme, which is the highest decay value again. And all these lenses have the lowest wetting angle, and which gives the best uh, comfort the patient. So all these lenses can be worn at a stretch of nearly 10 hours regularly with the help of this Quantamac Extreme material, because this is the lowest wetting angle material available, and also Hydra Peg coating, which gives the better comfort. So what does Hydra Peg coating do? It increases the wettability of the lens. It increases the lens surface water retentions, which helps in minimizing the deposits and lens fogging. So this is the major technique which technology which none of the other lenses have, because all other scleral lenses preferred they do wear them for 4 to 6 hours and remove them, refill the saline and again wear them. With these lenses, with Hydra Peg coating, that is not required. Patient can wear at a stretch of nearly 10 to 12 hours in a day at a stretch. Multifocals are also available with us, which means that the near multifocal aspheric designs and also the toric multifocals are also available. We have two multifocal variants. We have a center distance design and the center near design as well. This depends on the additional power what we prescribe. We also have something called as launched, which we launched recently, called as Keracare 3D lenses, which is free from design. It is also called as Maxim 3D outside India. So the specialty of these lenses are, all these lenses are made up of on-point technology, where a simple fitting patterns are advised, and empirical fitting is also possible. We use Pentacam, where upgrade is required using the Pentacam CSP design, and the software itself prefers what base curve, what diameter has to be fitted. So this is very helpful for the laboratory, where which also takes care of the scleral toricity as well. So any modifications like any 1 point modifications, each quadrant modifications, imagine if there's a branching only at one quadrant, like 3 o'clock position, we can only modify at 3 o'clock position, where other designs we have to modify all over the lens. We also have quadrant modifications where only 3 o'clock to 6 o'clock position can be modified. We can also alter the vault by increasing or decreasing at the center or in the limbus. So if the lenses are landing on the limbus, then we can ask to vault on the limbus. All these modifications can be addressed. We have something called as AccuVault, which helps in improving the comfort in pinguicula cases or any bell formations in such cases. This is the design where the edge of the design will be completely customized according to the sclera. The scleral toricity can be addressed as well. And this is the study on the centration of the lenses. IOLs do decenter, and that creates a lot of aberration values. And when it comes to contact lenses are also slightly decentered, or it is out of the pupillary area, the optic zones. In such cases, we can customize using this on-point technology. Keracare 3D lenses can be customized with optic zones. We can increase the optic zone, or we can even make sure that the optic zone is on the pupillary area by addressing these grids. So this 3 grids formations, if you see the center, this part, there are 5 grids totally, and the center, the second and the third and the fourth is in between the pupillary area. So then we make sure, write to the laboratory that 3 hash marks inside the pupillary area at 0 axis. The second thing, if we also see that here there are nearly 3 hash marks at 90-degree axis, and here it is nearly 4 hash marks. so which is at 45 degree. So we can also send the particular picture of these grid designs when we fit the lenses and ask the laboratory to do, or we can also mention these indications, whatever we see, so that the laboratory can clearly understand and can modify the lenses accordingly. So this is what we order for in such cases to alter the optic zone. So what does scleral lenses do? It is definitely a life-changing for all keratoconus patients or corneal irregular patients, because it gives the best vision, because it does perfectly shape the eyeball. It doesn't move, and it's more healthier because it's always baths with the saline, which is FDA approved for dry eye also. So it is also more comfortable because it doesn't touch your cornea. It completely goes beyond the limbus and rests on the sclera, which gives the better comfort. So this practice of contact lenses is very, very useful because it builds the person satisfaction and also the practice builder, which also makes the patient very loyal to you, which makes a difference for both patients as well as for us. Thank you, Giridhar Hospital, for having such a best presentation today. And this is from V Square. Thank you.
Thank you, sir. We have received some queries from our participants. One such question is it possible to incorporate multifocal and toric designs for keratoconus?
Yes, ma'am. Possible with Keratoconus scleral lenses. We have multifocal designs as well as multifocal toric designs as well.
Next one is blanching is a serious concern in scleral fitting. To how extent it can be resolved with the help of Keracare, sorry.
Yeah, blanching should definitely be not there with any of the scleral lenses. So Keracare has something called as on-point technology or customized modifications where we can flatten the edges or steepen the edges according to the requirement. So imagine if there's only blanching at one particular meridian, like I already told, if it is at 3 o'clock position, there's a blanching, and we can ask the laboratory to only flatten the lenses at 3 o'clock position. So Keracare scleral lenses are designed with CAD and CAM technology, where quadrant modifications or point modifications or edge lift modifications can be done.
We have one more question here. Most of the many scleral lens is advised for 6-hour continuous wearing schedule. But in case of Stevens-Johnson syndrome, it is for 2 hours. So what about Keracare?
Yes, that's a very good question, ma'am. Yes, the lesser the diameter of the lenses and the material, this makes that the comfort also reduce. We ask the patient to remove the lenses frequently and refill the saline. But with Keracare scleral lenses in keratoconus patients, because of this Hydra-Pec coating and also the Quantamac material, which gives the better comfort and increases the wettability, we can ask the patients to regularly wear at a stretch of nearly 10 to 12 hours in a day. They don't have to remove them. In dry eye cases, we advise them for nearly 6 to 8 hours, they have to remove the lenses. So it is definitely much better than any other scleral lenses in the market.
Thank you, sir. Now we came to the conclusion of this webinar. I welcome Ms. Asi Aman for the vote of thanks.
Good afternoon, all. On behalf of Giridhar Eye Institute and Sushrita School of Optometry and Visual Science, I would like to take this opportunity to propose word of thanks to those who have directly and indirectly contributed to Insight 2K22 webinar on role of specialty contact lens in keratoconus and myopia control. First of all, I spread my thanks to the Almighty for making this event successful. Next, I would like to convey my sincere thanks to Mr. Vikas Chaturvedi, General Manager of V Square Meditech Private Limited, for spending his valuable time with us and also enlightening us with the newest approach to myopia control and orthokeratology. Next, I would like to thank Mr. Swastik, Business Development Manager, V Square Meditech Private Limited, for sharing his valuable knowledge on Keracare scleral contact lens fitting. I spread my sincere thanks to Dr. Vinay Pillai, Senior Consultant, HOD of Cornea and Refractive Surgeries, Giridhar Eye Institute, for his session on interpreting corneal topography, which is a great help for the budding optometrist. an event of this dimension can happen overnight and needs meticulous planning and execution. So I thank Ms. Anu Kuriakos, HOD of Optometry Department, who played the greatest part in organizing and hosting this successful event. Moreover, I would also like to thank you for the interesting session on orthokeratology. Next, I take this opportunity to thank all the presenters, Ms. Parvati, lecturer of Sushrita School of Optometry and Visual Science, Ms. Jasla RV and Ms. Taslima NS, optometrist, Kirita Eye Institute, for their contribution in this event. I would also like to thank the entire technical committee who provided all technical support for the smooth functioning of this webinar, and also the participants for their valuable comments which helped to improve the quality of presentation. A special thanks to the organizing committee for their extreme support and coordination. Once again, I thank all of you for the participating in this webinar. By this, we have moved on to the end of our session. Thank you all.
Anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. These are the words of Henry Ford. By taking these words ahead, we are concluding our webinar Insight to K22. Thank you all.